This morning, we will open with a series of public hearings. We will begin with LD 1266 and then move on to LD 1268 and then LD 1317, followed by 1281 and 1331. That will be the order of hearings this morning. It's been ordered that are in other committees at this moment or have other obligations. So that is how we will proceed. And we will start right now with committee introductions. Representative Arford.
Thank you, Madam Chair. I am Poppy Arford and I serve.
My name is Tracy Quint. I represent House District 144, which includes Amity, Bancroft, Benedicta, Cary, Glenwood, Haynesville, Fulton, Macklehawk, Molunkus, Orient, Reed.
You have joined us. Please introduce yourself.
Thank you, Madam Chair. Foxcroft, Medford, Milo, Hornerville Township, and Lakeview Plantation.
Representative Brooks.
Good morning. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Representative Blyer.
Thank you, Madam Chair. Good morning, everyone. My name is Mark Blyer. I represent District.
Representative Matheson.
Good morning, everybody. My name is Christy Matheson, and I represent Cary District 1.
Representative Melorano.
Good morning. My name is Gina Melorano. I represent House District 62, which is part of Auburn.
Representative Morris.
Good morning. I am Representative Joshua Morris.
Thank you, Chair Tepler. My name is Heather Sambrook, and I have some other commitments today, so I'll be here for a bit. And then
Warren is my co-chair of the committee, the Senate chair, and I am Denise Tepler. I represent House District number 54, which is all of the town of Topsom, and I'm the House co-chair of the committee. And at least for part of the day, I'll be running our committee meeting because today by Kristen Ricci, our clerk, and our analyst is normally Colleen McCarthy Reed, but she is not available right away this morning, at least, as she is sponsored by our very own Senator Sanborn. And I'll invite Senator.
Honorable colleagues of the committee, I am pleased to introduce LD 1266, which is an act to improve the value of dental insurance. I don't think I've shared with the committee before, but my grandfather was actually a dentist, and my mom spent a few years as a dental health educator back when our public schools still had money to spend on such things. I was raised to appreciate that dental health and even having good looking teeth is important. But for long periods of my adult life, I didn't have dental insurance. So why not? Well, it wasn't because I couldn't afford it. As you'll hear today, dental insurance premiums are relatively small, $30 to $50 a month or so for an individual. And those premiums haven't risen nearly as much as the health insurance premiums have over the last couple of decades. And plus, it's pretty easy to buy dental insurance any time of year, even if your employer doesn't offer it. So why didn't I have it? Well, here's the thing that almost no one says out loud. Dental insurance is a really bad deal financially for almost everybody. Here's why. Unlike health insurance, where in-network co-insurance is usually about 20%, with dental coverage, you'll likely have to chip in around 40 or 50% of the cost of any filling or root canal you need done. And even then, the maximum that your dental policy will pay each year is capped. And it's capped at a pretty low number, often just $1,000 or $1,500. So let me say that again, because this is the opposite of what we usually hear about in this committee. Usually your out-of-pocket costs for health insurance are capped. Dental insurance is the opposite. The amount the dental insurer will pay is capped. at $1,000 or $1,500 or whatever your policy says. So that's the maximum value you're going to get out of the policy. Such annual benefit caps, as you guys know, are illegal in health insurance in Maine, but they're the norm in dental insurance. And generally, preventative cleanings are fully covered in dental plans, but paying cash for those cleanings would be far less expensive than paying your premiums. And often your dentist will even offer a discount if you pay without insurance. I would never go a day without health insurance because I could be in a car accident or diagnosed with cancer at any moment. I could need a heart transplant that my family could simply never pay for. Health insurance has no annual or lifetime caps. So as crazy as the premiums and deductibles are, it serves to insulate my family from huge financial risk. But dental insurance serves no such purpose. If things go really wrong in my mouth, my dental insurance will be maxed out, and I'll be on the hook for everything over the $1,000 or $1,500 anyway. And if things don't go wrong, I will have paid far more in premiums than those 2 cleanings a year would have cost me. So the value of dental insurance right now probably lies mostly in the fact that it encourages people to go to the dentist, since preventative visits are covered. But we'd all be much better off if we just stashed away our premium dollars in a savings account and used them to pay for those preventative visits instead of paying our premiums. Well, why is that? It's because your dental insurance plan likely spends only 60 cents of every dollar you pay on actual dental care. The rest goes to administration of the plan, overhead, salaries of insurance company employees, and profit. While the Affordable Care Act sets a standard for how much health insurance companies must spend on medical care, the same is not true for dental insurance plans. The ACA requires health insurance companies to have a medical loss ratio, sometimes called an MLR, of 80%, meaning they must spend 80% of premium dollars on things that benefit patients and quality of care. Since dental plans are not under the same requirement, they are currently free to spend as much or as little of the premium dollars as they take in as they see fit. Couple this with the fact that dental insurers can design plans in virtually any way they want using those annual caps, lifetime caps, and high co-insurance. And the dental insurers can really stack the deck in their favor. This bill seeks to bring some additional value into dental insurance. It does so by requiring dental insurance companies to report their loss ratio each year and by setting a minimum loss ratio of 80%, the same as small group plans under the ACA. If a carrier does not meet that 80%, they would have to give a rebate for the difference back to enrollees, just as health insurance carriers have to do under the ACA. And I would just note here that I asked Colleen to send around this morning the Kaiser Family Foundation's report that just came out with regard to how much health insurers are going to be rebating this year to the employers and individuals who bought coverage. And it's really quite astonishing. If you bought individual coverage, you are entitled to, on average, about $300 rebate based on the Kaiser Family Foundation study because of the MLR and because health insurers set their premiums so high that they actually didn't pay out the minimum amount needed to in health insurance claims. So if a dental plan doesn't provide oral health care with at least 80% of the premium dollars it collects, it does likely make more economic sense for a Mainer to pay for dental care out of pocket, just as I chose to do for many years. If you knew that for every $1 of premium paid, only 60 cents was paying for care, wouldn't you be hard pressed to understand the point of having the coverage? Dental coverage that meets an MLR requirement would result in more confidence for Maine consumers and employers that the dental insurance they are buying is worth the money they're paying, rather than just lining the pockets of insurance companies. You'll hear from insurance companies that dental insurance is very different from medical insurance and needs a larger administrative cost as a share of premium. But this argument just doesn't pass the straight face test. Just think of the number of different ailments and specialists and treatment modalities that are covered by health insurance. Everyone from chiropractors to endocrinologists to physical therapists to transplant surgeons, in every kind of healthcare setting, every kind of situation is potentially covered by health insurance. And add on to that prescription drug coverage with its prior authorizations and formularies and complicated administration. Health insurers cover all of this with an MLR of 80% or better, and have done so for a decade, while still making very strong profits and, over the last 3 years, paying rebates back to their members. Compared to that complexity, the argument that dental insurance should be relatively more expensive to administer per dollar of care, that just doesn't make sense to me. This law will force dental insurers to be more efficient, to design plans that provide better value to Mainers and that enable us to purchase dental insurance, knowing that it has some value. And that would be a win for Mainers. Thank you for your time. I'd be happy to answer any questions you may have, and the folks behind me can answer even more questions.
Thank you, Senator Sanborn. Any questions from the committee for the sponsor of LD 1266? Seeing none, I will, oh, yep, sorry, Representative Arford, please go ahead.
Yes, thank you so much, Senator Sanborn, for this bill, and thank you, Madam Chair, for recognizing my question. The ask that dental insurance be treated in the same way with the medical loss ratio. Is there anything else that we need to know about that as a committee in comparison with medical insurance, or what's happening currently with the amount of money? My understanding is that a great deal of money is being returned to healthcare, to medical private insured members, because there was a significant amount of funds that with the medical loss ratio was over the 20% allowed. If there's anything further you'd like to say about that, please do.
I mean, I guess I would just note that, and this has been our personal experience, I think probably of many people on the committee. I know I didn't have my teeth cleaned for a number of months during 2020. And I would imagine most of you didn't either. Dentists were closed entirely for a number of months because of infection control concerns. So the fact that the medical loss ratio isn't in place means that there's no accountability for what the actual experienced loss ratio might be for those dental insurers during last year's pandemic. So that's, something that I hope we'll ask the insurers about later in the hearing. But it certainly points out to me the need to hold folks accountable for ensuring that their premiums are appropriately calibrated with the amount of value in the plan, and that it isn't, 40% going toward administrative costs. And this is really about administrative efficiency, making sure the insurance isn't just designed to make profit for insurers.
Thank you.
Representative, oh, sorry, Representative Arford, you're all set? Okay, Representative Bleier, please go ahead.
Thank you, Madam Chair. Thank you, Senator Sanborn, for being here. I was kind of confused a little bit with a comment that you made in your testimony about insurance premiums being health insurance being reimbursed $300 because an excessive charge of health premiums. But because of the COVID pandemic, I mean, insurance companies, predict what potentially will happen. And because of the COVID scenario that we're in last year, a lot of people did not use hospitals, did not go to hospitals. And so the insurance companies predicted a certain amount. And because the COVID hit, those, care wasn't taken like in the past. And so they did not have to pay the premiums projected because a lot of people didn't go to the hospitals. And that's why the reimbursement happened. Am I correct in that statement? Or?
So thank you for the question, Representative Bleier. I think if you look at the Kaiser Family Foundation report, you'll actually see that rebates were paid out in the prior 2 years as well. and they've been escalating over the last 3 years. And so they're also paid out on a 3-year rolling average. So this year's rebates that the Kaiser Family Foundation released their study on today or yesterday, those are based on 2018, 2019, and 2020 blended claims experience. And so some portion of it is certainly the avoided costs from 2020, but there were rebates paid in based on 2017, 18, and 19 blended experience as well. And so 2020 was not an outlier. It was certainly a contributing factor, but Kaiser Family Foundation indicates that these rebates, have been paid out over the last 3 years consistently. And so what we heard back 10 years ago, or more than 10 years ago, when MLR was first put in place across the board under the ACA, was that it would be hugely disruptive, that insurers would not be able to reach this level of efficiency, and that it would be a huge problem. And that is not actually what's happened. Instead, these rebates have been paid out over a number of years now, and health insurers are incredibly profitable, and we see a lot of mergers and acquisitions activity. We see a lot of integration. So they're still finding absolutely ways to, make huge profits, but also operate under this 80-20 rule.
Thank you, Senator Sanborn. Are you all set, Representative Bleier? Okay, great. So seeing no further questions from the committee, I will turn to other supporters of the bill. And other than legislators testifying, we will be running a 3-minute clock. And first up, I'll invite Jonathan Schenken of North Yarmouth to join us if he's in the queue. Welcome, Jonathan Schenken.
Thanks for having me. Senator Sanborn, Representative Tepler, and members of the Healthcare Insurance and Financial Services Committee. My name is Jonathan Schenken. I'm a pediatric dentist in Augusta. I'm also a faculty in health policy, health services research, and pediatric dentistry at Boston University School of Dental Medicine. Much of what Dr. Senator Sanborn said earlier, I'm not going to repeat regarding the ACA coverage and medical plans, other than to state that in the Affordable Care Act, dental plans were accepted, meaning that they did not have to comply with this requirement that health plans had to. And this was not because dental plans are unique, have any kind of special structure that makes them, needing to avoid this. It's simply because the ACA didn't have mandated dental coverage. Dental plans are not unique, simply because we have this $1,000 to $1,500 maximum every year in claims, as Senator Sanborn mentioned. Virtually all of our claim submissions are electronic. A fraction of the codes, a minuscule number of codes compared to medicine, and no diagnostic codes in dentistry. And once a member hits this very low annual maximum, insurance companies are free and clear and have no responsibility in terms of billing and so forth. So just a few procedure codes in a year and a member can meet this maximum amount of money. In the state of California, several years ago, they did pass a law that required dental insurers to report their medical loss ratios. The lowest medical loss ratio reported in the state of California was 4%. That means 4 cents of every dollar paid by a subscriber or employer went towards the patient's care. 96 cents out of that dollar went to profits and administrative costs. That is unreal. Further in the paper, they showed that in the individual market, 52% MLR was the mean for dental plans, 59% was the mean for small group plans, and 71% was the mean for large group plans. What we're seeing here is cost shifting. Large group plans can negotiate better MLR ratios for their plans because they actually know what MLR is. They understand the value of MLR in dental plans, and small groups and individuals probably don't even know what MLR stands for, let alone what benefit it has for them in the health market sector. These health plans have been able to achieve 80 and 85% MLR in the ACA because of new efficiencies that they've achieved. So you're probably going to hear from insurance companies, they just can't do this. Oh boy. And what's important to understand is that if we actually, the time has caught me off guard. If we actually have this 80% MLR for dental plans, the claim has been by insurers that this will be too costly for lower income people. But if you have a low MLR right now, for people that are in individual market, 50 cents on the dollar going towards their patient care, they're having to take more money out of pocket to pay for their care than if they had an 80% MLR and the insurance company was actually paying for their care.
Dr. Schenken, can you wrap it up, please?
Sure. So in conclusion, this bill of proposing an 80% MLR for dental plans will create value for consumers, less money out of pocket. And even if premiums do rise in the individual market on some level, that money will be used directly towards patient care. So claims that this will make patients unable to afford care is an erroneous statement. Thank you, and I'd be glad to answer any questions if you have.
Questions from the committee for Dr. Schenken? Yes, Representative Matheson.
Thank you, Madam. Thank you, Dr. Schenken, for testifying. I'm a provider as well, a healthcare provider who does all of the billing in my clinic. So I'm just curious, what do you see in terms of billing? Who do you work with insurance companies, and how difficult is that as an administrative level for you as a practitioner in your practice?
And we do everything electronic submission, and we have a third party that does billing as they do in healthcare as well. And I think that things have changed since I started practicing dentistry over 20 years ago, where we were doing all paper claims and trying to chase the tail of submissions. So things are much different, simple, straightforward. Very few technical issues occur in claim submission since everything's done electronically. It's almost like you don't need humans today in dental insurance companies, because things are so simplified with claims.
Okay. Any other questions from the committee for Dr. Schenken? Seeing none, we will move on to others testifying in favor of the bill. And I will call Angela Westhoff of the Maine Dental Association.
Yes, thank you, Representative Tepler. So good morning, Senator Sanborn, Representative Tepler, and distinguished members of the Health Coverage Insurance and Financial Services Committee. My name is Angela Westhoff, and I am the Executive Director of the Maine Dental Association. The MDA, as you know, is a statewide association dedicated to advancing excellence in dentistry. The MDA represents 85% of the dentists here in Maine, and we have 774 practicing and retired dentists who are active members of our association. On behalf of the MDA, I'm pleased to provide testimony in support of LD 1266 and the significant benefit it provides to thousands of Maine individuals and families. First and foremost, it is important to note that medical loss ratio established by the Affordable Care Act on health plans did not result in a mass exodus of health plans across the country. In the decade since the ACA has been in place, adequate choices remain available to consumers and employers seeking benefits for employees and their families. The MDA is cognizant of the fact that individuals and families with dental insurance are more likely to go to the dentist. But if a dental insurance plan isn't providing 80% of the premium dollars it collects on actual oral health care, then doesn't it make more economic sense for the patient just to pay for that dental care out of pocket? If you knew that every dollar spent on premiums, that just 60 cents of that dollar was going towards care, wouldn't you prefer to put that dollar in a designated savings account? An MLR requirement for dental plans in Maine will result in more confidence that dental insurers are devoting most of the premium dollars collected to actual care. Furthermore, a loss ratio will encourage dental plans to be as efficient as possible with the premium dollars they collect and ensure that consumers are getting the best possible benefit. And lower income families with tight budgets will actually benefit from a loss ratio for dental plans. Their premium dollars, whether they fully pay the premium or their employer picks up some portion of that premium cost, this will allow them to get as much care as possible for the dollars spent. Having a plan that has 40% of every premium dollar going to the dental insurer for internal costs doesn't give the family the bang for the buck that they deserve. A loss ratio in dental insurance simply gives patients the opportunity to understand the value of the product that they're purchasing. This committee has spent a great deal of time over the last few sessions discussing transparency, and transparency is what LD 1266 seeks. Thanks for your time and attention. I'd be happy to answer any questions now or at your work session.
I'd love to be a fountain of knowledge and more.
Thank you, Ms. Westhoff. And now I see a question from Representative Morris. Go ahead,
Yes,
Representative Morris.
Yes, thank you, Madam Chair. You spoke a little bit about better value in the premiums. Do you know what the premiums might be if this legislation were to pass, what that might change the premiums to?
Thank you for the question, Representative Morris. It's a great question. I don't know off the top of my head, but I would be happy to consult with my client and try to get some information for your work session.
Okay, thank you. And just as a follow-up too, what do you expect the dentist reimbursement rates would be if this were to pass as well?
Could you rephrase the question? What do I expect their reimbursement rate would be? It's, they bill dental codes, so D codes. So there's a value established by the dental insurance company.
Okay.
Yep.
I mean, do you expect that would raise those rates?
Not necessarily. I mean, I think what this bill seeks to do is just like, nutritional labels on food. A loss ratio simply gives the patient the ability to comprehend the value of the product that they've purchased. So if they've purchased a dental insurance plan, this would ensure that more of those dollars are going to direct care as opposed to administrative costs. I mean, certainly we appreciate that there's a cost to do business, right? Many of us own businesses and run them, but we're just trying to ensure that the greatest value of those dollars are going into direct care. So that's that 80% threshold.
Okay, thank you.
Yeah, absolutely. Good question.
All set, Representative Morris?
Yes, I am.
Thank you. All right. Thank you for your testimony, Ms. Westhoff. Seeing no further questions from the committee, I'll move on to other folks in favor of the bill, and I will call Kate Endy of Consumers for Affordable Health Care.
Good afternoon, Representative Tepler, Senator Sanborn, and members of the committee. My name is Kate Endy, and I am the Policy Director at Consumers for Affordable Health Care. We are a nonprofit, nonpartisan organization that advocates for affordable, quality coverage and access to healthcare for all Maine people. As you know, we serve as Maine's consumer assistance program for health insurance. As such, we assist individuals in enrolling in private health insurance coverage, largely through the marketplace. At the end of that application, individuals are given the opportunity to select a dental plan. The vast majority of individuals that I've personally worked with through this process typically don't opt to enroll in one. Because looking at the benefits and looking at the cost of that plan, it's often not worth it to the individual to pay for that coverage. As Senator Sanborn already pointed out, oftentimes dental plans aren't a very good deal for people. In preparation for this hearing, I was running some estimates for various carriers offering dental plans in Maine. And based off of an adult living in Presque Isle, Maine. And, there was variance, but Notably, there was, as an example, one plan where the premium would have cost slightly over $500 for the year that limited the amount that they would pay in benefits to $1,000. There's also waiting periods for various services that lasted either 3, 6, or 12 months, which means someone would have to pay $500, more than $500 for coverage for an entire year and potentially not be able to get the major restorative services they needed. And then would have to potentially pay the same premium the following year before they would have access to that coverage, at which point they've already paid in premiums more than that plan is going to pay out for the services that they've been waiting to get. For every child who has asthma, there are 5 children who experience tooth decay. Tooth decay is the most common chronic childhood disease and is more likely to occur in children who don't have routine access to dental care. And it can impair speech development, socialization, difficulties associated with lower performance in school. Into adulthood, dental decay can have lifelong consequences on someone's health and economic well-being. Data from hospitals across Maine have shown that emergency department visits resulting from dental needs have increased over the years. And a report from 2010 by DHHS and the Maine Health Access Foundation found that the top diagnostic reason for visits to the emergency department for uninsured people ages 15 to 24 and 25 to 44 was dental disease. We know that cost is a barrier to care and that people will often put off care until they can no longer put it off because of how painful it is.
Ms. Endy, can you please wrap it up for us?
Sure, absolutely. We are very supportive of this bill because it would ensure that people are getting what there's value in what somebody is buying, whether it's an individual or a small business buying dental plans for their employees, and that the amount that somebody's paying in premiums correlates to the value of the plan that they're going to get in benefits. And I'm happy to answer any questions, but I'll just say that in our opinion, increasing the medical loss ratio requirement would not necessarily correlate to higher reimbursement rates for providers or higher premiums. It just means that a larger share has to be spent on actually paying claims or quality improvement. And so if
Ms. Endy.
All right.
Thank you. Yes, Representative Morris, go ahead, please.
Thank you, Madam Chair. I just wanted to touch a little bit on the last comment you made in terms of the premiums. Do you think there would still be $30 monthly premiums if this bill passed?
I think this bill is focused on the percentage that's being spent. And so right now, if carriers only have to spend 50% of their premium dollars on care, then if they are going to, they would have to either reduce their premiums or raise their benefits in order to comply with the medical loss ratio. And so, there's been comments about it would, just increase, reimbursement rates to dentists or providers. We would hope that this would also increase benefits that people have for the, $30 or $40 or $50, whatever they're paying, that amount is correlated to the benefits that they are provided.
Thank you, Ms. Endy. Are you all set, Representative Morris?
Yes, I think so.
Any other questions from the committee for Ms. Endy? Yes, Representative Brooks, please go ahead.
I was wondering, the Consumers for Affordable Healthcare, how often do you see people calling that already have large bills for dental care or have reached their cap and need help with that?
We certainly hear from people who are trying to access dental care, and often in a state of, I'd say, desperation of, they are in so much pain and they just haven't been able to come up with the money to get the tooth pulled if they need to. and afterwards to be able to, whether it's dentures or whether it's other restorative services, to be able to access the care they need. And ideally, people would have access before that happens, right? So, preventative care, and that's great. But if you're already struggling to pay for health insurance premiums, pay for your rent or your mortgage, food on the table, then paying for a plan that's only going to cover preventive isn't always a priority, especially if you know that there's going to be waiting periods for covering other services that you need and that you're going to have to end up paying out of pocket. So I'd say we definitely hear from people through our helpline that I think could benefit from this bill.
Are you all set, Representative Brooks?
Yes, thank you for your help.
Yes.
Thank you.
Okay, and Representative Bleier has a question. Please go ahead, Representative Bleier.
Thank you, Madam Chair. Thank you, Mrs. Undy. My question for you, Mrs. Undy, is that so there's no doubt dental care is important, right? I think it's more than the people that are uninsured who can't provide insurance who need dental care, because good dental hygiene is good body health in general. Well, my question to you is that according to Senator Sanborn, that 60% of premiums are spent. So if we're trying to get to 80, we're saving about 20%. Will that 20% really make a difference? Because people are not purchasing a dental care now because it's too expensive. And so if we have to increase it to 80, that'll increase the premiums even larger. So will that throw even more people out of the market and make dental care even less affordable?
I think it doesn't necessarily have to increase premiums. I think there was the point raised that it could also lead to increased efficiency and to lower administrative costs. And so I don't think that a higher MLR necessarily has to correlate with a higher premium. And if there were a higher premium, it would have to correlate with richer benefits, so people would be getting more out of their coverage. And so I think that, it could either, reduce premiums, because now only 20% could be kept for administrative costs and profit. So it could cause premiums to go down, or it could cause the level of benefits to actually increase, so that people who are paying, whether, $30, whatever it is that for their plan, now have more benefits for the amount that they're paying for. I'm not sure if I answered your question or not, but
yeah.
Okay.
It looks like Representative Bleier is all set. Any other questions from the committee for Ms. Endy? Yes, Representative Matheson, go ahead, please.
Thanks so much. Thank you, Ms. Endy. If I understand you correctly too, when you see consumers coming to you and talking to you about dental insurance, it's not necessarily the premium that stops them from getting dental insurance. It's that it's what they're getting out of it. Correct? Am I hearing you correctly on that?
I would say we see both. So, when people are calling our helpline because they are in, excruciating pain, they have an infection, they need to get it dealt with. Usually, oftentimes it's because they don't have dental insurance, but oftentimes when we're helping people enroll in coverage and the option to enroll into a dental plan is, comes up at the end of the application when enrolling to a marketplace plan, and people are kind of having that conversation, and, based off of the premium cost, many decide not to enroll in a plan. Particularly, the premium in relation to the benefits it's providing, but often just the premium in and of itself as well.
Thank you. It looks like Representative Matheson is all set. And I'm just going to ask what I think is a clarifying question for the committee, Ms. Endy, if that's okay. So if right now it costs me $1,000 over a 2-year period to get $1,000 worth of benefits from my dental plan, and my medical loss ratio increases to 80% from approximately 60% now. And the cost of my plan goes up to $1,200 or $600 each. I'm sorry, $1,200 per year. But I'll be getting more benefits out of that. They would have to provide me with $1,000 or $900 worth of benefits out of that $1,200. Whereas now I might not get that from my plan on an annual basis. Is that correct?
Right. I mean, I think that, you know, the way the medical loss ratio is calculated, it doesn't require that plans either, you know, increase or decrease their rates. It just requires that they're meeting this ratio. So it could look a few different ways. Perhaps, you know, if rates do increase, but then benefits increase along with them. Or perhaps if benefits don't increase, then, you know, rates could decrease because the amount of benefits of being paid aren't great enough to justify the higher rate. And to clarify, you know, the plan that I was referring to, you could receive some benefits, you know, beforehand, but if you were looking for, I believe it's for major, you know, restorative care. But if you went in knowing that that's what you needed, you'd have to wait till the second year. So, but just want to make sure I was clear about that.
Thank you. I think that does clarify. And appreciate your testimony and answering all the questions. And next we'll turn to Catherine Kilrain Del Rio of Maine Equal Justice to testify in favor of the bill.
Thank you.
Thank you.
Good morning. Good morning, Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Kathy Kilrain Del Rio, and I'm the Director of Campaigns and Healthcare Advocacy for Maine Equal Justice, a nonprofit legal aid provider working with low-income Mainers to increase economic security, opportunity, and equity for people in Maine. Today, I am submitting testimony in support of LD 1266. Dental care is health care. Our mouths are a vital part of our bodies, and the health of our mouths can have an enormous impact on our overall health, our self-esteem, our employment, even our relationships with our families. Dental care should never have been separated out from other health care. The way our healthcare system grew and the ways in which certain body parts, like our mouth, became disconnected from the rest of our body when it comes to health insurance makes them seem less important when they aren't. That's why 1266 makes sense. It corrects a wrong by requiring dental insurers to report their medical loss ratios to Maine's Bureau of Insurance. It also sets an 80% minimum medical loss ratio for dental plans in our state. If a dental plan spends less than 80% of premium revenue on patient care and quality improvement, they must give the difference back to their enrollees through a rebate. When California required insurers to report their medical loss ratios to the state, it was revealed how disparate the investment in patient care could be. While insurance companies are businesses that seek to make a profit, the priority should be investing in the health needs of their enrollees rather than high salaries for their management or other administrative costs that don't benefit those paying the premiums. By requiring dental insurers have a medical loss ratio of 80%, Maine could significantly reduce the out-of-pocket costs our residents spend on dental care. In turn, that could increase Mainers' use of dental services for needed preventive and complicated expensive procedures. Improving the oral health of Mainers should be our collective goal. We've begun to shift the way we describe dental care with the recognition that it isn't an extra, it isn't a luxury. Dental care is health care, and we should align our requirements for dental insurers with those who provide other health coverage. For these reasons, we urge you to pass LD 1266. Thank you for the opportunity to speak today, and I'm happy to answer any questions you have.
Thank you very much for your brevity, Ms. Del Rio. I appreciate it. Are there members of the committee with questions for Ms. Kilrain Del Rio? Yes, Representative Matheson.
Thank you, Madam Chair. Thank you, Ms. Del Rio. I just wanted to clarify I've heard a few times that California did a study on the MLR for dental insurance, if I understood you correctly. And have there been any other states that have mandated this? And if so, have they seen any increases in dental insurance rates?
That's a good question. I did not come across other states when I was preparing for this hearing, but I can look into that before the work session.
Thank you, Ms. Kilrain Del Rio. Does anyone else on the committee have a question for Ms. Kilrain Del Rio? Seeing none, thanks for your testimony. And now I'll turn to the queue and ask if there's anyone else who is with us in the attendee list who would like to testify in favor of the bill. Seeing no virtual hands go up, I will turn to those speaking in opposition to the bill. And first, I will bring in Stacia Almquist of Unum. There she is. Okay, welcome, Ms. Almquist.
Thank you very much. Thank you for your time this morning. Senator Sanborn, Representative Tepler, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is Stacia Almquist, and I am Vice President of Network and Market Development for Unum. Unum has been a presence in Maine since 1881 and currently employs roughly 2,800 Mainers. I appreciate the opportunity to speak in opposition to LD 1266. This bill inappropriately applies a medical loss ratio requirement and rebating requirement to dental plans. The current proposal of an 80% minimum loss ratio for dental plans will create higher administrative expenses, particularly in rebating small dollars to individuals and groups on an annual basis, and will result in higher premium costs for individuals and groups in Maine, as well as other unintended consequences. As you've heard from several people, dental is different from medical, and I believe that should be considered in any discussion around an MLR requirement applying to individual or group dental plans. Dental plans are a low-cost, single-benefit health product, and a larger percentage of a low-premium product is used for administrative costs. Dental plans are frequently requested by consumers and are highly utilized benefit as well. The dental customer service call centers receive thousands of calls each week from members, from brokers, and plan administrators and providers. And dental plans pay tens of thousands of claims each week to providers and members. The administrative costs for individual and small group plans are higher percentage of premium than for larger group plans, which is also something to consider. Different dental plan designs will have different level of benefit costs and administrative costs. Having a single minimum requirement for all dental plans, regardless of group size, individual coverage, or plan design, may result in loss of dental coverage options for individuals and employers in Maine, as well as an increased premium cost. Adding a rebate requirement on a lower cost dental plan is going to further increase administrative costs for carriers and will increase administrative complexity for employers. Imposing a rebate requirement on a dental carrier on a product that's lower cost could, for example, result in a rebate to an individual member of a group of around $6 on a monthly premium of $52 per member for a PPO plan, if that loss ratio is 1% lower than the minimum requirement. Dental plans will have that administrative burden to determine the appropriate period of time to calculate the minimum loss ratio for a group, determine what is owed, and then distribute back to the employer. An employer will need to determine how to allocate the premium rebate received back to employees, particularly if that coverage is partially or fully employee paid. Requiring an 80% minimum loss ratio for dental will increase premium costs and eliminate low-cost plan options. Because dental is very price sensitive, individuals and employers may choose to drop their dental coverage if the cost increases. Data from the National Dental Association shows that consumers with commercial dental coverage are more than twice as likely to use their dental services. If the number of consumers in Maine with dental coverage decreases due to premium going up, this could lead to a decrease in dental services being accessed an increase in the use of emergency rooms to access those dental services. For all of these foregoing reasons, UNUM opposes LD 1266 and requests that the committee vote not to pass. Thank you again for the opportunity to express our opposition.
Thank you, Ms. Almquist. Yes, I see a couple of questions from the committee. Representative Evans, please go ahead.
Thank you, Madam Chair. Thank you, Ms. Almquist for being here. I had a couple of questions. Maybe you can clarify, why are the administrative costs so high?
For dental plans,
For
the
dental
administrative
plans?
costs, it really has to do with the way that we're allocating those premium dollars. We do pay the benefits on the dental insurance plans, but we also have the call centers. A lot of the administrative and regulatory complexities that you hear medical carriers have also apply to dental. So we have to do all of those things on a lower premium base. And then as a percentage, you're going to see those be higher. And I'm not saying that there aren't places that we can all improve efficiency. That is what we carriers are trying to do. And we're always striving to be more efficient, automate as much as we can, because we do have high volumes and lower dollar claims that we're paying. So we're trying to increase that efficiency. But overall, there just is a higher percentage that's utilized for administration and regulatory compliance.
The other question that I would ask is, what are the contents of a basic dental plan?
The contents, well, the dental plan designs can vary, but in general, they're going to cover 100% of the cost for preventive services, because that's really important. I think that's part of why members go to see the dentist when they have commercial coverage, because their preventive is covered. Then oftentimes there will be an 80% or 50% coverage for other types of services. And there is an annual maximum on most plans. Now, one thing to remember is when we're designing these plans, we're designing them for the employers typically, because group coverage is very common, to be able to offer in an affordable price. So the more benefit we include in the plan, the more cost that there is, and it is a very price sensitive market. So you'll hear people talk about the value of the dental plan, but you have a premium you're paying for to have access to a dentist, to have access to in-network providers that have been credentialed, but also to be ensured that for the things that we typically need to go to twice a year for dentists on preventive, those are services that are covered by almost every dental plan. But they can vary depending on what an employer wants to be able to cover or what they can afford to cover for their employees.
The final question that I would ask is, what's the maximum?
The annual maximum?
Yes.
It depends on the plan design. So you'll hear common maximums can be 1,000, 2,000, sometimes 1,500. Ultimately, that annual maximum is provided to the employer group when there's a group coverage based on what that employer would like to see. So you can see a variance in what those maximums are based on the plan design and the premium price point that an employer group may be looking for.
Is there a range?
A range for the annual maximum? Yeah, there can be as low as $750 up to $3,000, sometimes higher, depending on what a group would like to see.
Thank
I
you.
think the most common is 1,500.
Thank you.
You're welcome.
Okay. All right, Representative Matheson, please go ahead.
Thank you so much, Madam Chair, and thank you for testifying. I just wanted to ask you, in the pandemic in 2020, did your members see fewer dental services during that time? And if you did, what did your insurance members do with that excessive revenue?
Now, certainly when the dental offices were closed, which started happening in April through May or June, there were fewer services being accessed. We did have teledentistry options that were available for emergency services if a member needed to see them. So certainly the utilization of dental services was very muted in those couple of months where we saw nearly every dental office was closed. But I would say by third quarter and fourth quarter of this year, we saw nearly every dental office was open again, and we saw a return of utilization of those benefits. I think dental offices were seeing 80 to 90% of the revenue or of the members that they were seeing pre-pandemic by the time we got to September, October or so. So we started to see an increase in the utilization, members being able to go back or feeling more comfortable to go in and get their annual cleaning, getting their checkups or get serviced for, fillings or things that perhaps they didn't get taken care of during when dental offices were closed. So utilization did come back. And so we're seeing members now as well. So what we have looked at in terms of having fewer claims, obviously, in April and May, is how much did that uptick through the rest of the year and into 2021? Because if we did delay our care as a person because we weren't comfortable going in, it's possible we'll see higher severity. So what could have been a filling may end up needing to be, a crown at some point if you wait long enough. So we've seen that utilization come back towards the end of the year, and we're seeing it be higher and back to pre-pandemic levels now. I hope that answers your question. If not, I can clarify further.
Representative Matheson, are you all set?
I think so. I'm not sure it answered my question, but I understand what you said.
Thank you. And next up is Representative Bleier. Go ahead, Representative Bleier.
Thank you, Madam Chair. Thank you for your testimony. Thank you for being here. We heard with the previous people in favor of that passing this bill, creating a law, would increase inefficiencies and create either lower premiums or more care. Which one would this create, lower premiums or better or more care? Which one do you think it would do by passing this bill into law?
I don't think it would do either of those things, in my opinion. I do think that it will increase premium potentially because we will need to still, as a carrier, make sure that we are providing the benefits that are required under this bill, but also able to do any rebates if that's required, as well as cover all of our administrative expenses. So I don't see it in decreasing premium. I do agree there is always some incentive to increase efficiency. So there would be continued incentive to increase efficiency to get closer to whatever that requirement might be from an administrative cost perspective, but I don't see it decreasing premium. My concern too is some of the current plan designs that employers like to see in the marketplace that are lower cost, such as a lower annual maximum. Some of those may not be as feasible, or they'll be higher cost and they won't be as low cost for the employers to purchase with an 80% minimum loss ratio.
Are you all set, Representative Bleier? Okay, thank you. And Representative Melorano.
Thank you, Madam Chair. If I could, I'd just like to ask Representative Matheson's question in a more direct manner. And that would be, what exactly did Unum do with the extra revenue that they would have been able to hang on to due to their members not receiving treatment as much last year?
So during the pandemic, Unum took several different tacks to make sure we responded to our employer groups as well as to support the dentists. So one of the things we did is for groups that were coming up for renewal, because if you think about the annual renewal process, dental being a trended product, costs of dentists go up every year. And that cost of care typically increases. For groups that were under 100 lives, we did not increase premium if they renewed from August 1st of 2020 up through April 1st of 2021. So we kept those costs down for those groups. And on groups that were larger, we looked at those on a case-by-case basis as well. And we were considerate of what that premium needed to be because there was lower utilization for those couple of months. We also allowed for reinstatement for employers who might have rehired somebody due to all the challenges during the pandemic. 6 months since their termination date, we would reinstate those employees at the same premium rate and made sure that their deductibles and their annual maximums, that any waiting periods, those were all still satisfied if they were able to rehire those employees. And then we did things like we did some PPE, so some protective equipment reimbursement for our dentists because we know that those costs were higher. So we tried to support our dentists with that by reimbursing a flat fee for dates of service from April 27th through July 31st to help with that increased cost of supply and demand. overall. And then we've done some things within the community, working with the food banks to donate money there, donating some PPE in some different areas. So we've tried to do that, but ultimately, those were our responses while we're maintaining and watching for that increased utilization as well. And we will consider that for groups as they renew and where we're at overall in terms of the product and the way that it's performing, because the employer groups, and we expect some utilization to go back up. So we're trying to work with our groups to make sure that we understand what that looks like and we take that into consideration.
Follow up, Representative Melorano?
No, thank you.
Okay. Thank you. I have a question for you, Ms. Almquist. It seems to me that from your testimony, the biggest objection that UNUM has to this bill is the issue of having to deal with the rebates as part of the bill. You said that administrative costs would increase because you might have to deliver rebates as little as $6 to individual members. So if this bill called for those rebates to be delivered to the groups rather than to the individual members, like the HR department of a group, would that reduce your concerns enough that you might support the efficiency portion of this bill?
Well, when I was saying that I was quoting an individual, but I didn't anticipate that we would actually reimburse to that individual of a group. I was just trying to show what the dollar amount might be if we were to miss it by 1%. We would expect to deliver it back to the HR department or the administrator of the plan for the employer group. And then that adds complexity for the employer to determine as well, because most of the dental coverage is not fully employer paid. There is some, but oftentimes it is partially or sometimes all paid premium by the employee. So I wouldn't say that's our biggest objective. That is definitely something that I wanted to make sure was considered, because it does add a lot of administrative complexity, not just for us as a carrier, but also for the employer groups and how they return that money back. Because for dental, we're talking about a much smaller dollar amount relative to the medical premium that might be rebated. And then the other thing that is really around the one size fits all, I think, is really challenging from a minimums perspective, because it depends on the group size, the plan design, and it may have some unintended consequences and make less options available for employers in Maine.
So your concerns are primarily about the employers who buy the insurance through UNUM?
We do sell mostly group coverage, and I think in Maine a lot of the dental commercial is done by group employers, less so for individuals. So my concern was really around the employers and a one size fits all for the dental minimum loss ratio, and what that level should be different.
And if the employers support the 80-20 split and are willing to take on the administrative complexity that you've outlined, then what?
Then, yeah, so if the employers are willing to take that complexity, that's one aspect of it, but the administrative cost and the premium cost will still increase for most likely for the dental plans. And so there will be differences in options, increases in cost that can impact how many members or how many employees would like to choose and to have insurance, which can affect, as I said, it will affect the number of visits you'll see to the dentist as well, and can have an impact on overall health if we don't go to the dentist.
Well, thank you. I'm a little confused, but thank you for taking the time and testifying. And next, I will call Ms. Canalati of the National Association of Dental Plans, Teresa Canalati. Welcome, Ms. Canalati.
Hi, I hope everyone can hear me. Thank you, Senator Sanborn. Thank you, Representative Tepler, and distinguished members of the committee. My name is Teresa Cagnolati, and I represent the National Association of Dental Plans. I'm here today because the state of Maine and the people of Maine are actually very important to a number of carriers. In Maine, more than 1 million people, that's 76% of the entire population, currently has dental benefits. And NADP represents 30 companies that provide dental coverage. Nationally, NADP members provide dental HMO, dental PPO, dental indemnity, and other dental products to 200 million Americans with dental benefits. And I'll talk just a minute about how a bill like this that sets just one standard for all those different types of plans and all those different coverage types, that just doesn't make sense, especially for a low-cost product like dental insurance. But as I said, the people of Maine are important to dental plans, and this isn't just lip service being paid here today at the committee. We have put our money and our services where our mouths are. And that's why when Maine made the bold but smart decision in the absence of CDC guidance to go ahead and open up all those dental offices last year in May, we were right there with you. We were there as carriers, making sure not only that people could return if they wanted to, but that they could do so safely, that dental offices were supported in the reopening, that folks who were laid off or furloughed could continue to be covered, that people who couldn't see their dentist could see one out of network or wait to see theirs and still be able to have that covered even when the plan year ended. So you'll see as an attachment to my written testimony and spelled out in the body of my longer letter, a list of things that carriers have done actually nationwide to help customers, to help employers, the community, as Stacia mentioned, dentists themselves. Why? Because as we all know, and as has been stated numerous times throughout the course of this hearing, that good dental health is good overall health. There's dozens of scholarly articles about this, and I think we can all agree that this is very important. So now I understand that Senator Sanborn, who's the chair of this committee and the primary sponsor of this bill, like you, she's a small business owner. So I know that means that as business owners, you all probably understand a lot more than I do about the cost of doing business. You know about the overhead, you know about what it takes to keep the lights on, you know about what you pay your employees, and maybe even make a little bit of profit at the end of the day. But what I do know is that first and foremost, in your mind is how to serve your customers and about how to provide them with value so that they keep coming back and so that they're happy. And you know that whether it's furniture or beer that you're moving, what that customer actually thinks is valuable is about that product itself. So, and it reflects what they're willing to pay based on what they're getting. So how do you measure that? That's really the question that brings us all here today. And unfortunately, the answer cannot be found in this bill any more than it could be found if you had a limit on what you pay your employees or spend for the price of hops per bushel. It's not going to be able to tell your customers how good your product tastes or what the alcohol content is, if that's what the actual value is to them.
Please wrap it up, Ms. Carnellotti.
Absolutely. So I just would like to, at this moment, invite both you, Representative Tepler, and you, Senator Sanborn, to work directly with us and our members to help try to figure out what value means and to help try to figure out how we can better serve folks in Maine without setting an arbitrary and, quite frankly, unimportant number when it comes to what actual customers are looking for. And we respectfully oppose the bill and are certainly willing to work with you through the work session. Thank you.
Questions from the committee? I see Ms. Matheson has her hand up. Please go ahead, Ms. Matheson.
Yes, thank you very much. Thank you, Ms. Cannelloni, for testifying and being with us today. I have the same question to you for your membership as I did to the last person that testified. I'd like to know, did your membership see fewer dental services over 2020, and what did your membership do with that extra revenue to support your patients, not your insurance?
Right, and thank you for that. And I'm just going to go ahead and echo what previous statements have been made about what was done, because I think most dental plans took similar measures. Steps were taken nationwide, and that might actually be a good thing for us to report on We gave credits or refunds to premiums and policyholder on premiums to policyholders. We did rate freezes, we did deferrals, we did a number of financial accommodations to policyholders, relaxation of waivers and frequency limits that we've been talking about here today was also part of it. Waivers on deductibles, the annual max rollover that you've heard about, modifications to eligibility requirements to allow employees to remain in the event that they were furloughed or laid off. Expansion of coverage to include teledentistry was another thing that came up, or even just temporary services could now be covered under the plan. We increased reimbursement rates too to dental healthcare providers. I know you asked me specifically about customers, but just so you know, we actually did help out the dentists as well in the state, and we provided loans and grants to them even, and we did provide donations in support of local communities. Low income, historically underserved communities were high on the list. And I would certainly be happy to get, I think, more detailed information to you and other members of the committee about what last year looked like and what last year could potentially mean when it comes to evaluating. I can't necessarily speak for a lot of the financial details around our association, but I'm happy to get that information to you.
Representative Morris.
Yes, thank you, Madam Chair. Thank you for being here. Can you just kind of touch on the history of 80% medical loss ratio under the Affordable Care Act and also why dental insurance was excluded?
Yeah, and thank you very much for that question. I think we all have to go back to the extent that we can even remember, we have to go back to 2009 and start to think about some of the conversations around medical loss ratios at the time. Maine is actually unique. New Hampshire, and 2 other states, Vermont, and I believe Rhode Island, although don't hold me to that, actually already had a medical loss ratio in place when the ACA was being considered. So there was a lot of conversation during the ACA. Numerous groups weighed in, but one of the primary groups to weigh in was the National Association of Insurance Commissioners. And I think some of the data that you've been hearing coming out of the proponents of this bill reflects reporting that is being done by plans to the insurance commissioners. And the National Association is the group that gets together and meets of all the insurance commissioners. And they weighed in and they said that 80% simply will not work for dental. They had all the data. They had folks, certainly folks that are much smarter than I am, look at it and make a determination that medical loss ratio that was set for medical would simply not work for a low-cost product. But what was also happening, and I think this is something we all forget because the ACA has changed so much over the last now going on 11 years, is that there was a mandate put in place to purchase medical insurance. And that there were also subsidies being provided for the purchase of healthcare insurance as well. So some of the concerns that we are raising here today about the increased cost of premiums and about folks dropping coverage were not considered at the time because you had a mandate on coverage and you had premiums being offset by subsidies. So this is kind of a little bit of the history, and it's why numerous states, including I heard California being raised several times here during the conversation, have not set an MLR for dental. It is because they have all this information, and even with the very detailed reporting that's coming out of the state of California, no one has taken that information and said, okay, well then that means that 80% is a good MLR for dental. Quite the opposite. What they've seen from all that information that they've been able to gather is that you have this wide variation, and it also simply would not make sense because they understand the impact that would have on the market and their constituents.
All set, Representative Morris?
Yes, thank you very much.
Thank you. And I have a question for you, please, Ms. Cagnolotti, and it probably isn't one you can provide today. But as the national association that represents all or most of the plans, can you give us an average of plan profits over a 3-year period, including 2020, like for each year, so we can take a look at that amount of profit? That would be very helpful.
I can certainly go back to our members and talk about what we could potentially provide. It was with respect to claims and other data to the extent that they have that available through the end of 2020. You know, you're right. I don't have that information readily available today, and that is certainly something that the National Association would have to then peg members to provide to us. I would say that what we would do if we were to gather that information would be to aggregate it and anonymize it based off of research protocols. But I'd be happy to get back to you on what that process might look like, potentially how long it would take, and whether or not it's even feasible from a research standpoint to get that to you.
That aggregating it and anonymizing it, I completely understand, but I guess I'm a little surprised that the National Association of Dental Plans does not track the profits of its members over time. The fact that you don't have that data already really surprises me.
Right, and I think this might be a matter of us understanding what is defined as profits over time, right? I think this is really more of a sense of, you know, I want to make sure that what we get to you actually reflects what you're trying to see. And I think maybe we should have a conversation about what, from all of the data we've collected over the past more than 25 years that we've been in existence, can be derived from our members.
I think that the word profits is fairly clear. I don't think that it's that confusing. I think that when one fills out a tax form, one deals with costs and the money that's left over after costs are fully paid. So I really think that the word profits is understandable, and expect that you would be able to give me some response about that.
Okay, and I would also point you to the National Association of Insurance Commissioners, where plans to actually report in this information, and there's publicly available data on insurance industry, what we're calling profits.
I don't know that the NAIC actually collects profit data, but I would expect that the National Association of Dental Plans probably does. So hopefully at the work session, you'll give us some information on that, that trend and how it looks.
Yes, I'll be happy to report on that.
Thank you. I appreciate that very much. And thank you for answering our questions and for being present for the public hearing. And now we'll turn to Ms. Cindy Goff of the American Council of Life Insurers.
Hello, can you see me and hear me?
Welcome, Ms. Goff. Thank you.
Thank you so much. I very, very much appreciate the opportunity to talk with you all today. I wish that I could be there because your state is one of my favorites to visit, but hopefully someday we'll be able to be there in person with you. My name is Cindy Goff, and I'm speaking on behalf of the American Council of Life Insurers. We represent most of the life insurance companies in the country, and a relatively small number of them actually also are dental carriers. And so I'm speaking on behalf of the dental carriers that are members of the ACLI. We're talking, as you all know, about LD 1266. And I just wanted to, I'm not going to repeat a lot of the information that was given to you because it sounds like you all have a very good grasp of the details of what's in the bill. I just wanted to stress a couple of specific concerns that I wanted to raise on behalf of our members related to the bill. I think that the major concern, as you have heard, is that 20% of the premiums for dental products would really only give folks about, on average, about $8 per month to administer the policies. And that when you compare it to, for example, that major medical plans usually have about $150 a month to administer, when really, when you look at some of the business requirements and the quality assurance requirements, network and contract and claims payments, and customer and provider service functions, when you compare those with the cost for medical they're not that much less. And so, so the concern would be that that in order to be able to adequately meet the customer service needs and all of the administrative needs, you would actually need to add benefits by raising premiums. And in so doing, dental insurance is so very price sensitive that the concern for our members is that they would see a lot of members dropping coverage. And additional concern of that dropping of coverage is obviously that you see less dental services being used then. And then when you're constructing networks, then it makes it harder to sort of like make it of value to the providers to actually participate in the networks, which is one of the sort of values that people are able to give people who buy dental insurance is the ability to use networks and high quality networks. And because dental insurance is so price sensitive, the other concern that we would have is that especially because the administrative costs are different for small employers versus larger employers. This might actually create a lot more difficulty in our members who specialize in serving small employers. It will just be difficult for them to keep their business base because you will see small employers dropping coverage. And that the worst case scenario under that obviously would be that some carriers would just feel like they would no longer be able to serve customers in Maine, which would be in their minds a horrible outcome because Maine is very important to them.
Can you wrap it up, please, Ms. Goff?
Yes, absolutely. I think that those were in general my comments, and I am very happy to take any questions that you have.
Thank you. Yes, Ms. Matheson, go ahead. I mean, Representative Matheson. Sorry.
Thank you, Madam Chair, and thank you, Ms. Goff. I think that it would be easier to understand where your testimony is coming from and also previous testimonies if we actually really saw what the administrative fees are currently and what you think the administrative fees would be with this bill. Hard for me to believe as a healthcare practitioner that dental insurance is more complicated than healthcare, or even close to being that complicated, being the person that does all of the billing. So I guess I just would ask, do you have information for us so that we can believe that this administration fee is really going to be significantly greater? What is it currently? What will it be given this bill? And then I would have just a little more information on understanding where you're from. Thank you so much.
Yeah, no, that makes sense, and I think that if that would be helpful for the working group, I think that we can give you that information just to kind of break out like what the administrative costs are, because I don't think we're saying that it's as much as medical, but it's not like significantly less than medical either, and so I think that that's what we would like to be able to show you.
And just one other request for the work session, Ms. Goff, if you could provide us with any data that you have on the price sensitivity of dental insurance, since you mentioned it several times,
Yes.
would be helpful.
Yeah, in fact, we did a study for California when they were considering this, and by we, I mean the industry as a whole, and we are actually working to update that information for the working session now. Your legislature is so efficient that we didn't have time to get it done for this hearing, but we will definitely try to have it done for the working session.
Thank you. Okay, seeing no further questions from the committee, I will call Courtney Morin from Northeast Delta Dental. Thank you for your testimony, Ms. Goff.
Yes, thank you.
I don't see a Courtney Morin on the call.
Okay. So we'll move on to Mr. O'Neill of Delta Dental Plan of Maine. Welcome, Mr. O'Neill. Can you unmute and turn on your camera if possible, or at least unmute? Mr. O'Neill, are you there? Well, while Mr. O'Neill comes back to, that is not Mr. O'Neill. That is Ms. Moran, I believe.
Sorry, I don't know why I'm under his name, but I will proceed if you're ready for me.
Yes, we are. And please just make sure you introduce yourself and say who you are and who you represent.
Absolutely. Senator Sanborn, Representative Tepler, and members of the committee. My name is Courtney Moran. I am an actuary and vice president of actuarial and underwriting at Northeast Delta Dental. I'm here today to oppose LD 1266. If passed, this bill would decrease access to dental care. As you've heard, the ACA did not apply mandated loss ratios to dental plans for good reason. Dental is different. Dental carriers face the same regulatory requirements and operational challenges as health plans, despite charging premiums on average 1/20th of the cost of a health plan. Because medical premiums are so high relative to dental, the ratio of administrative costs to dental premiums is inherently higher, leading to a much lower loss ratio. As a result, imposing loss ratio requirements on dental favors and promotes the most expensive, least affordable dental products. Consider the impact of the 80% mandated loss ratio for the small group and individual marketplace. Such a requirement gives a health plan charging $500 a month, $100 to administer that plan, while a $30 dental plan gets only $6 to administer the plan, which is not enough to pay for plan operations, compliance, broker commissions, and consumer services. Affordable dental plans do provide value. A loss ratio developed specifically for medical plans does not capture dental plans' value to consumers. As an example, Delta Dental's most affordable individual plan in Maine costs less than $30 per month, covering diagnostic and preventive at 100% and basic restorative services at 50%. For a patient with 2 diagnostic and preventive visits, 1 basic restorative visit for filling and a visit for a crown that is not covered by the plan, an uninsured patient in Augusta will pay approximately $1,936, while the insured patient visiting a PPO provider will pay $748 less, far more than the $350 cost of the plan in the first place. Loss ratios are already reported to the Bureau of Insurance and regulated under Chapter 940 of the Maine Insurance Code. When the need arises, such as during the early stages of the pandemic, Delta Dental worked with the Bureau of Insurance to receive regulatory approval to provide premium relief and rate holds to our customers as part of our broader COVID relief package, which totaled over $10 million in Maine alone. This also included provider relief. If this legislation were to pass, insurers would be forced to create richer plans, driving the premium costs up and reducing the number of Mainers with dental plans. This would have a detrimental impact on the overall and oral health of Maine residents, increasing medical costs for chronic and high-cost conditions, and increasing visits to the emergency room with dental-related issues. With a set loss ratio, certain plans, such as those for individuals and small groups, would be the first to be dropped from the insurer's portfolio. In fact, if this legislation were to pass, Delta Dental would consider we would consider withdrawing offering plans on Maine's healthcare marketplace due to cost pressures. Increasing premiums with a loss ratio requirement is in conflict with helping more Mainers gain access to an affordable dental plan. These higher costs diminish access to dental care and reduce competition in the dental insurance marketplace, particularly for small groups and individuals, is why it ought not to pass. Thank you. I'd be happy to answer any questions.
Thank you, Ms. Moore, for sticking to the timing. I appreciate it. Any questions from the committee? Yes, Representative Morris.
Yes, thank you, Madam Chair, and thank you for being here today. Just sort of toward the end of your testimony, you were talking about different plans and prices and so forth. In your analysis, if this were to pass, do you have any idea what the cheapest plan Delta would be able to offer in the state of Maine for an individual?
Yeah, so currently our lowest price plan is, as I mentioned, right around $30, $29.48. In our small group and individual marketplaces, we would have to raise our premiums on average 28% to accommodate the 80% loss ratio. So on the lowest cost plan, that'd be bringing the premiums up to about $40.
Thank you.
Before I call on Representative Arford, I'd like to remind the committee that we've now spent an hour and a half on this bill. We need to make sure we're not rehashing things that we've already discussed, and that questions we're asking will actually be dispositive when it comes to making our voting happen. So with that, Representative Arford. Please
Very quickly, thank you, Madam Chair, and thank you, Ms. Moore. Very quickly, I was very excited when I became a legislator for lots of reasons, and one small part was that I now have Delta Dental Insurance, which is in network, the only time I've ever been in network with my dentist, where I live in Maine. And so I want to make sure I understood what you just said. Did you say that that if this legislation was to pass, that Delta Dental would consider leaving the state of Maine, which means they would leave their contract with the state of Maine to provide dental to people like myself, dental insurance?
We would have to consider leaving the individual market, such as the health insurance marketplace, or you're switching to a state-based exchange. So we would consider not participating in that state-based exchange next year, where we currently already have 3,400 individuals covered, but it'd be cost prohibitive with an 80% mandated loss ratio to continue participating in the exchange.
Okay, but you're not considering leaving your contract with the state of Maine?
For large groups, no.
Okay.
Okay, and seeing no other questions from the committee, thank you for your testimony, Ms. Moran, and we will move to Ms. Ossenfort of Anthem Blue Cross Blue Shield.
Chris O'Neill is on the call if you wanted to circle back.
Oh, okay. I guess maybe I should call Mr. O'Neill. I apologize, Ms. Ossenfort. We'll get to you next. Mr. O'Neill, welcome.
It's good to be here, Representative Tepler and members of the committee. I'm Chris O'Neill from Portland. As you know, I'm the lobbyist who represents Delta Dental before the committee. And you'll be pleased to know that part of my testimony was to introduce Courtney Moran, so I'll skip that. The talk about this bill, much of the discussion is focused upon value. And there are libraries full of books and white papers that explore the interrelationship of cost, price, and value. And a universally agreed upon economic principle is that value is what purchasers believe a product or service is worth to them. So when Consumers for Affordable Healthcare, Ms. Endy said that some consumers choose not to purchase, they're making a value decision. And for that matter, when people look at the Delta Dental Covers Me exchange, not the state exchange, but the one that we run in addition on our own, they have a choice of a $30, a $40, $50, $60, even up to a $90 plan, whether they're an individual or a group. And groups, as has been said by others, tend to self-design to an even greater degree. But one usually ends up with a plan that provides value that is commensurate with the price. So to cut to the chase on the conjecture as to whether this legislation would increase premiums, it would do so in a couple of ways. One, as Ms. Moran said, we would tend to just drop the lower value plans because we would likely not have much enrollment in them. And we would be forced to, whether it's finding efficiencies or what have you, pay more to providers. We'd be forced to increase the costs. Again, value is many things, but one thing that it is not is easily regulated. A consumer measures value, whether it's a low premium, a higher copay, a lower copay, a quick paid claim, or a friendly voice who answers on the first ring at the call center. We can cut the call center out to create efficiencies, but how would consumers value that act? Beware unintended consequences. Like in California, loss ratios are already reported to the Bureau of Insurance. California does not have a mandate like is proposed today. And the Bureau of Insurance does have records of our loss ratios. If they're testifying today, I would imagine you could request that. But applying the same loss ratio to the health plan world versus the dental plan world is not going to work for all the very good reasons that have been mentioned earlier. Last, I urge you to log on to deltadentalcoversme.com and look up the range of available plans available to you. You just need to enter your birth date and your zip code, and you'll see what's available and the various levels of value that people are free to choose when they sign up for a plan, which is any time of year. And by the way, waiting periods are no longer in force, thanks to Senator Sanborn from last year, the bill that we supported. But for all the foregoing reasons, and I'm happy to answer a lot of the questions that you asked, there are several questions that you asked that went unanswered. Delta urges you to vote on, not to pass on this well-intentioned, but really unnecessary legislation. Thank you.
Thank you. Questions from the committee for Mr. O'Neill? Seeing none, I will next call Ms. Ossenfort, Christine Ossenfort of Anthem Blue Cross Blue Shield.
Thank you, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. I am Christine Ossenfort. I am here to testify this afternoon in opposition to LD 1266. And I apologize in advance. I'm getting messages that I have an unstable internet connection. So I will try to be very brief. I don't have anything to add. We would echo the concerns that you have already heard from other opponents of the bill. And I would offer in response to Representative Matheson's question, and I believe Representative Melorano also asked it, we did provide premium credits to our members last year. We did also reimburse our dental providers for PPE of $10 per visit from June of last year through the end of 2020. We did cover and allow for and encourage teledentistry. And with that, I will be happy to answer any questions you may have, and I will be present at your work session this week.
Thank you so much for your brevity, Ms. Ossenfort. Does anyone on the committee have any questions for Ms. Ossenfort? Seeing none, thanks for your testimony. And I'll next call Brad Peak of Sun Life.
Thank you for the opportunity. I'm going to put myself on video. Hey, it's great to be with you today, Representative Tepler, committee. Really appreciate the time to talk about providing access and value to dental consumers and members in Maine today. I think that's our mutual objective. But I want to just spend a couple of seconds. I'm with Sun Life, 60,000 employer groups across the nation, 500 employees of Sun Life in Maine. So pleased to be here. The dangers of talking in terms of percentages versus absolute values. And we've come across this issue before in other states from time to time. I want to tell you why most states have not passed MLRs. Often this is looked at through a medical lens. If it's good enough for medical, why is it not good enough for dental? Aren't they the same thing? But if you think about medical and what the average person is paying for medical on a monthly basis, roughly $600. And if you take that think that of that $600 in terms of a pizza, and you take 20% of that, that's $120 to do all of the administrative things that you need to do for a medical plan. That same pizza and divide it up into 20 pieces and take one of those pieces, that's roughly what somebody's spending on medical, all right, around $30. And then you take 20% of that tiny little slice, and what you have left is what that MLR would be, right? And so if you think about a $16 plan, a very low cost plan that a lot of people would want to have, a DHMO plan, that's about $3.20. Compare that $3.20 to the $120 of medical, and it makes no sense anymore. In fact, it's too low to do all of the things that a dental company has to do. Build a network, negotiate rates with providers, sell through brokers and representatives to employers, pay claims, customer service, all of those things for each member each month. And so when you hear some of us say we would have to leave the market, shut down low-cost plans for the most vulnerable people, that's what we're talking about. It becomes unaffordable for us. Someone asked, what is the profit margin for dental companies? Well, roughly in the industry, I can't speak for everybody, but after-tax profit margin, between 3.5% and 5%. We don't operate, we have a lot of efficiency already built in. We're forced to. You've got a lot of dental players in Maine. Maine's got a good thing going, a lot of access, 75%. It's a lot better than a lot of states. We can always do better, but there's a point where it only adds to cost and doesn't add to value. Okay, so thank you. I'm happy to take your questions.
Thank you very much. Mr. Peak, questions from the committee for Mr. Peak? Oh, seeing none, we appreciate your testimony. And next we'll call on Mr. Rose of MetLife.
Hi, good afternoon.
Good afternoon, Mr. Rose.
Good afternoon, Representative Tepler, Senator Sanborn, and distinguished members. I'm going to direct you to the written testimony we submitted. And I first want to apologize. The first time I submitted it in Word form, so the formatting is a little longer than it needed to be. I submitted another copy, so I do apologize about that technical snafu. I don't want to repeat because you've been very attentive and patient, and we really appreciate the opportunity to speak to you today. I won't go through all of the points that have been made. In our testimony, we did highlight, because I think it was Representative Matheson and a number of other members did talk about what is the difference between dental and medical. And we do highlight in our third paragraph, sort of an example of what the costs are for medical and how that breaks down per month and what the DLR, what that impact would be on much lower cost dental plans that we offer. For example, we have some that are priced at $360 a year. That comes out to about $30 per month. So an 80% DLR in that circumstance would provide about $72 a year, or just $6 per month for the administrative functions, the same administrative functions that have to be followed in the medical world. Those were just alluded to by Mr. Peak: processing claims, operating call centers, offering language assistance, maintaining networks, ensuring timely access, complaints and grievances. The list goes on and on. So it's not a lot of for the amount of administrative services we do provide. And I just want to highlight as well, and it's in our written testimony. We as you believe that good health begins with good oral health. And we think that was evident in MetLife's response to the pandemic in 2020. We did provide a 25% premium credit for the months of April and May when many practices were shut down. And we knew that our insureds had less access during that time period. And we also wanted to try to meet the challenges that our providers and our networks experience due to the higher costs associated with PPE. So we elected to temporarily increase our payment under our fee schedules to help offset those costs. We work very hard to keep our dental premiums low. We want to try to provide as many people with the ability to purchase affordable dental coverage. I think that's the goal of each of you on this committee. We look forward to working with you. I'll be happy to take any questions. And again, I just want to say how much I appreciate the time. I will say that my son's mother has recently become a Mainer and is a full-time resident of your great state in Cushing. So my son believes he's a Mainer as well. So when he goes to visit, he has all but good things to say. So thank you for your time, and I will be glad to take any questions.
Thank you very much, Mr. Rose. Questions from the committee for Mr. Rose? Seeing none, thanks so much for your testimony. And now we'll turn to Jeff Wallawender from Community Dental, speaking in opposition to the bill. Mr. Wallawender?
Hi, good afternoon, committee. First off, thank you for your hard work, service to the state, and incredible patience for these meetings. As the Executive Director, Chief Dental Officer, Tufts School of Dental Medicine Clinical Instructor, and a full-time active practitioner at Community Dental Maine, I have been a frontline public health dentist in Maine for over a decade. We see a variety of patients from all walks of life, including working poor, who often have smaller or less comprehensive dental plans that are more affordable versus the premier ones. These are the dental plans that the insurance companies will be more likely to drop because these are the ones that do not typically comply with that high dental loss ratio. And I personally think that will relegate lower income people to no longer having dental insurance. Having dental insurance is proven to make people more likely to go to the dentist and provide more access for lower income patients to visit private practice offices. Without these insurance types, there will be a potential undue burden on clinics that offer sliding fee services, further perpetuating inequities among income disparities. These insurance companies negotiate the fees dentists are able to charge for their members. The American Dental Association does the average fees charged by dentists for all regions of the US, including the Northeast, and that's available online. The average fees for these dentists is significantly higher than what the insurance companies negotiate. Individuals are not able to negotiate fees. This is the reason people do not want to pay out of pocket and like dental insurance. We can already see what happens with adults without a preventive benefit. It's called the Emergency Adult Main Care Dental Benefit, and it doesn't work. People do not come in for checkups and maintenance, even with a sliding scale, but they do come in for emergency care because they have something of a benefit. And that is a risk for passing this legislation. This is disastrous for individuals, not the big business. I'm not concerned with maximizing dental profits or insurance company profits. I am concerned with lower income people getting access to the dentist and having affordable care. This bill does not tackle either one of these issues, and in some instances counteracts that. The legislator should be focused on areas that could expand access for these people, especially an adult Medicaid preventive and comprehensive benefit. Thank you all for listening. Happy to answer any questions, and I beat my 3 minutes.
You did indeed. Thank you very much, Dr. Wallawender. I appreciate your testimony very much, and I am confused about why you still confused about why you feel this is so problematic for the members of our main community who are lower income. I guess I don't understand how expecting more value for their dollar, despite the difficulty of measuring value, is problematic.
Sure. So, they're the ones who are more likely to be purchasing on, the exchange or Delta Dental covers me. These are the plans that are going to increase. I've been seeing patients who haven't had dental insurance for some time who end up on some of these plans starting to come in and see the dentist for the first time. If you don't have dental insurance, you're typically going to be waiting until something bothers you, and it often is way too late, and a cascade of your mouth has already happened where you're, if one thing's hurting, most likely there are other things going on. But, it's the individual group plans that are going to suffer. I mean, those are the ones that I think some of the insurance companies testified that these are the ones that they can't afford to meet that loss ratio, whereas a big group plan is easier to meet that loss ratio. So as they start dropping the individual plans, which may be smaller businesses or smaller groups, that is going to affect the patients that I see. So, and that's what we see in some of our more rural areas where it might be smaller offices, smaller areas, smaller businesses. We see these smaller individual plans versus, a big corporation that has, or like Maine Medical, which has tons of, employees with the benefit. That's what I'm concerned about. And if they're saying, which is what several of them testified, that those are the plans that aren't going to work for them, those are the people that are going to lose dental insurance. And if they go to a private practice office, they're subject to whatever fees that dentist is going to charge, which is, I can guarantee you, higher than a PPO plan for sure.
So how do you suggest we deal with the fact that that often the purchase of a dental plan, whether it's an individual plan or a group plan, ends up for many people not being worth in care what they're paying out in premiums?
I don't know the full answer to that, but I mean, I would probably rewrite this one and maybe come up with something where the insurance company combined has to do it, not just separating all the individual plans out and saying, this is the dental loss ratio that you need to do, or maybe a different number would be something. 80% from what I can see from what, Delta Dental has and what maybe some of the other ones has might be a little bit too high. I'm not necessarily opposed to it, but if it's risking these individuals losing theirs or getting higher fees, I am way opposed to it. And that seems to be the way it's written here today.
Okay. I appreciate very much your testimony. Is there anyone else on the committee with a question for Dr. Wowelander? Seeing none, thank you so much for your testimony. And that is the end of my list of people speaking in opposition. Is there anyone else in the attendee list who would like to speak in opposition to LD 1266? Seeing no virtual hands raised, I'm going to move on to those speaking neither for nor against the bill. And first I will call on Superintendent Chapa if he's in the queue. And let's see. Is Superintendent Chapa with us, Christian? Oh, yes, he is. Great. Superintendent, welcome.
Welcome, indeed, and I'll try and be brief and just add information that you may not have heard. As you said, Senator Sanborn, Representative Tepler, members of the committee, I'm Superintendent of Insurance Eric Chapa, and I'm here to speak for or against LD 2012-66. Currently, dental plans loss ratios are governed under Rule 940, and they can range from 50% to 60%, depending on the renewal provision of the policy. No rebates are required under current law if the loss ratio is not met. The target loss ratios of carriers currently rating ranges from 60 to 65.5%, and the actual experience loss ratios range from 65 to 70.5%. As of 2019, there were 52 dental carriers reporting premium in Maine for group and individual dental insurance policies. The majority of these carriers write group policies. For example, there were about 551 million in total premium written from 2015 to 2019. This includes approximately 500 million in group dental premiums and 50 million in the individual dental premium. The largest carrier accounts for 59% of the total premiums written. It is unknown how carriers may react to this higher MLR, as you've heard, and it may be some carriers may reevaluate their position in Maine. And there are currently 15 carriers approved to sell individual dental policies in Maine. Of those, 3 are currently selling adult and pediatric standalone dental insurance on the exchange, down from 8 carriers in 2014. I hope this information is useful. I'd be glad to answer any questions. And by the way, we do have, and I can provide it to work session, we did compile the carrier's reaction to the COVID situation and what rebates and credits they offered policyholders, and I can provide that at the work session.
Thank you, Superintendent. We appreciate that. And I guess we'd also like, if possible, some kind of graphic of the current MLRs for those carriers as well. And I see that Representative Bleier has a question. Go ahead, Representative Bleier.
Thank you, Madam Chair. Thank you, Superintendent Chapa, for being here. My question, and I want to make sure that I heard you correctly. If this law were to pass, you feel a lot of carriers may leave the industry, or potential may leave the industry, which would leave less options for the patients?
Like I said, it's unknown. I mean, it's really, you heard, you don't know. I mean, the carriers expressed that concern. I think it's a possibility, but you really don't know. And it's just, I think I use the word unknown. I'll leave it at that.
Thank you, Superintendent. And we have a few more questions from the committee. Representative Quint.
Thank you, Madam Chair. And Superintendent, I'm just wondering, I believe his name was the gentleman that was on prior, he was talking about the rural areas, and I'm wondering if you have any data at all that shows how many of the smaller group plans are involved in that area, where if they pulled some of those out, would that leave our rural areas much less availability as far as plans are concerned?
I'm not aware if we have that data, but I'll check.
Thank you.
Okay, and there we go. Representative Melorano. I knew there was another hand. Go ahead, Representative Melorano.
Thank you, Madam Chair. Thanks, Superintendent Chapa. Just a couple questions, and if you want to bring the info back, that's fine too. But one of the questions is, do you think this will have an effect of like raising the reimbursement that a dentist gets for any one particular service, or raising the reimbursement rates to dentists?
We heard a lot of comments on, it's really, in my opinion, it's what the fixed costs are that the dental insurers have. They describe it as, customer service, network adequacy, negotiation, and so forth. Those fixed costs are fixed. And so if the MLR goes up and they have costs that are constant, then you have to raise expenses somewhere else, and that could be in reimbursement. Again, to me, the key question is, what are the fixed costs that the carriers have, and what can they, and if those are fixed, they have to raise expenses somewhere else to meet the MLR. So that's, I don't know the answer, but that's the key question, I think.
Okay, thank you. And if I may, Madam Chair, another question here. Are there really higher administrative costs for dental plans? I mean, I get that there's sort of a smaller pie or whatever, but 20% versus 40 to 50% is quite a difference in terms of administrative costs. I mean,
and that goes back to the fixed. It's a very good question, and that's why I focus on the fixed costs, because fixed means just that they don't vary with volume per se. I mean, there's a little variance. So what are fixed costs, and if those are higher as a percentage of premium, then it's, that's the answer to the question. And that's what I think you should ask the carriers. What are your fixed costs, and look at those. And if they're, if they are higher, then that's a legitimate concern that they have to raise expenses elsewhere. If they're not high as a percentage of expenses, that being fixed costs, then you come out in a different place.
Okay. Thank you.
All set, Representative Melorano?
Sure. I feel like I didn't get a ton of info, but and I ask you, Superintendent Chapa, because I trust you as a source, maybe more so than the carriers who might be a bit biased. But
I can explain it well. Again, I'm focusing on fixed costs because the whole issue is here. They're saying their admin costs as a percent of premium are higher. And the reason for that is the fixed costs are higher. And that to me is a central question. If that's true, and I don't know off the top of my head, I'll admit that. Well, I'll see what data we have. But if that's true, in order to meet the MLR ratio, you have to raise expenses somewhere else, which means raise premium. If it's not true, then the answer is no, they don't have to. They don't, if the fixed costs are not as high as a percentage of premium as they say they are, then you would not have to raise rates.
Okay, but even you are not sure, essentially.
I'm not sure. No,
Yeah.
I'll see what information we have.
Thanks so much. I do appreciate that. Thank you, Madam.
Of course. Superintendent, I guess in conjunction with Representative Melorano's question, we'll ask you and anyone else who's listening to provide us whatever information they can on the fixed costs of those providing dental plans in terms of their dental plans, not in terms of all the plans that they offer, which I'm afraid is where the data starts to get a little skewed also. So we'll ask for that information as for the work session. Okay, and now we have a few more people speaking either for nor against. So I'm going to call Jeffrey Dow in from Detroit. Mr. Dow? Can you turn on your mic and your camera? Mr. Dow? Okay, well, let's just leave Mr. Dow.
Do you have me now? I'm sorry.
Yes,
So-
that's okay. I have you.
Okay, am I on video or just audio?
Just audio.
Well, rather than mess up this computer, if it's all right with you, I'll stay there. Is that fine?
That is fine.
My name is Dr. Jeff Dow. I'm actually a dentist. Have practiced in the state of Maine for 40 years. And proud to say that for all 40 of those years, more than a third of my population has been Maine low income, Maine care. I also spent 32 years in the Maine Army National Guard, testifying neither for nor against because in 8 more work days, I won't be a dentist anymore. I've managed to find 3 graduates from the University of New England to take over my practice, and life will be fishing and more than that. I will say, having testified since Mike Mishu was president of the Senate many years ago, there's certain things that I always seem to hear in these bills. Number one, I don't hear enough about the consumer, the patient. I hear a lot about dentists and I hear a lot about insurance companies, but to me, the patient should be the primary focus. I also know that one of the greatest ways to kill a bill in the legislature is simply say it's going to raise cost or to bring up unintended consequences. However, I don't know that I've seen unintended consequences in the healthcare plans since the Affordable Care Act was instituted. I also want to say in full disclosure that I was a former board member of Community Dental Center, and seeing how the current director was talking before, I do think I ought to make that point. I'm not sure that you don't have a false premise when you're told that insurance rates or the cost of insurance will go up. What I am sure is this bill gives you the opportunity to ensure that more of what the patient pays or the company pays for the patient will go to meet their out-of-pocket expenses. The bill will have no impact on what dentists charge. I never set a rate in 40 years based on what an insurance company paid. Their insurance companies are not going to raise what they reimburse dentists off this. The money will go for the patient to meet their out-of-pocket expenses. I've treated Maine's low income for years. One of the problems you have with some of the low plans is the patient doesn't realize they don't cover anything. They purchased something of little value, but that was never explained to them. And certainly this bill may cause plans of little value to go away. And that's unusual for a dentist to say, well, sometimes no plan is better than a plan of little value. That's actually exactly what Senator Sanborn said earlier today. So maybe there will be less plans, but the plans would have adequate value. As far as community dental centers concerned, they also have sliding fee schedules, and you're probably not going to see that in private practice anywhere, in the same way that federally qualified health centers get cost-based reimbursement versus a dentist who does it. This bill calls for transparency. The legislature doesn't understand how dental insurance works. The consumer doesn't understand how dental insurance works. The patient has no idea of the value of the product they are purchasing. Simply allowing patients, employers, and individuals to evaluate the value of what is being sold is a good thing. There is no standard. The legislature can create a standard. As I said, I have no dog in this fight. In 8 days, I'll be fishing more. And my only decision will be whether or not, based on Maine's tax status, whether I have to declare residency in another state. I support this bill because I support my patients and I support my consumers. Rebates could simply have a minimum attached to them. No one's saying you have to rebate 25 cents. And I will end because I can see your time. Thank you.
Thank you very much, Dr. Dow. Any questions from the committee for Dr. Dow? Seeing none, thanks very much for your testimony. And we'll move on to Judith Feinstein of the Maine Oral Health Coalition, if she's on the call still.
Hi, can you hear me?
Yes, Ms. Feinstein, go ahead.
All right, I'm just going to try to bring up the video. Sorry. Okay, Representative Tepler, members of the committee. My name is Judy Feinstein. I live in Hollowell, and I serve as the coordinator of the Maine Oral Health Coalition. I want to let you know, too, that until a few years ago, I spent many years in the Maine CDC as the director of the oral health program. And if Dr. Dow is still on the call, I'd like to say good afternoon to him. I want to offer comments on behalf of the coalition on this bill. We were founded over 20 years ago as the Maine Dental Access Coalition. So we maintain a very close interest in policy and systems change that can work to improve access and services and also to improve oral health status in Maine. I did submit written testimony. I'm not going to read it verbatim. I would echo many of the things that you heard, particularly from Senator Sanborn, Ms. Endy, and Ms. Kilrain Del Rio, and some of the things that Dr. Dow just said. I also really want to commend you all on your questions. It's been a long 2 hours and some of the most instructive time I've spent in a long time. I learned a lot from your questions and the answers that you got. But I will reiterate that for people with dental insurance, the premium costs and the co-payments do result in high out-of-pocket costs. And many people, including myself as a former state employee, wonder about paying the premium rather than saving the money. So I think that this bill offers a real opportunity, I think, as Dr. Dow just explained, to really look at how do we manage dental coverage in Maine. And I'm going to be just going to cut right to the end, where I personally and representing the coalition are very interested in the full range of actions that Maine can take to make all healthcare services accessible and affordable. We will all be healthier that way. It will cost us all less money. And we'll all get a good value from it. So in very simple terms, this bill has the potential to reduce the amount that patients pay out of pocket on dental care and insurance costs, making dental care more accessible and more affordable for many people in our state. And we'd want to see that because then the coverage they do have will go further to keep them healthy. And that's it. That's all I'd like to say. I'd be happy to answer any questions and to sit in on the work session if it works out. Thank you so much for your time.
apologies. Thank you very much for your testimony, Ms. Feinstein. I am getting texts from committee members and things at the same time, so I accidentally muted myself. But thank you. And are there any questions from the committee for Ms. Feinstein? Seeing none, thanks for your testimony. And next, and actually last but not least on my neither for nor against list, I have Dr. Finocchio of Blue Sky Consulting.
Good morning, everyone. Let's see.
Good morning.
Oh, there's my video. Thank you for having me. Madam Chairperson, Senator Sanborn, and distinguished committee members. I'm Len Finocchio. I'm a principal consultant at the Blue Sky Consulting Group, which is in Oakland, California. And we're a public policy and economics consulting firm specializing in strategic and analytic services for public, nonprofit, and private sector clients. My background is I am a former California Medicaid agency official. Previous to that, I was involved in health services research, which is what I'm currently doing, and also have had positions in health philanthropy. So you've heard a lot about the background of medical loss ratios and the Affordable Care Act and how the ACA did not set minimum MLRs for dental plans. I've heard California come up a number of times. So in 2014, a California law was passed, which required dental plans to report their MLRs, but it stopped short of setting minimum MLR threshold, although there was an attempt to do that in the initial bill. And when it was amended, the MLR threshold was removed. But since 2014, dental plans in California have been reporting their MLRs to the state. So we were hired by the California Dental Association in 2017 to analyze 2 years of dental MLR reports. And we looked at the numbers that were reported against 3 MLR thresholds: the Affordable Care Act threshold, a bill that was in the California legislature at the time that would have established MLRs at 70% and 75%, and also thresholds or recommended by the National Association of Insurance Commissioners, which is 60%. And the results of our study was published in the peer-reviewed journal Health Affairs in September 2018. And it sounds like some of you have probably seen that paper. And just quickly, because I'm running out of time already, just some high-level highlights of our analysis of California dental plan MLRs for those 2 years, 2014 and 2015, is that few of the products in California achieved the Affordable Care Act MLR thresholds of 80 and 85%. Most Californians served by dental plans with MLRs some did meet the NAIC threshold of 60%, and some did meet the thresholds of the Senate Bill 1008, which was 70 and 75%. And importantly, MLRs differ by product size and by type. Generally, the more lives that are in a plan, the higher the MLR. So it could be that some of the large plans in your state already have achieved an 80% MLR. PPO products were more likely to reach MLR thresholds than were HMO products. And we found that in California, 3.8 million and 1.2 million Californians served by products were not meeting a 70% threshold or even a 60% threshold. So there are millions of Californians who were not receiving value from their dental plans.
Please wrap it up, Dr. Finocchio.
Okay. So lastly, some implications that larger plans can achieve minimum MLRs. It's very challenging for plans to deliver value because they're so different. A legislatively mandated MLR could offer a remedy and ensure better value for dental products. And you may consider MLRs that differ by different types of dental plans. And I'll leave it at that.
Thank you very much for your testimony. Any questions from the committee for Dr. Finocchio? Seeing none, we do appreciate your testimony. And now I will ask if there's anyone else in the attendee panel who would like to testify neither for nor against LD 1266 and act to improve the value of dental insurance. Seeing none, I will close the hearing on LD 1266. It's now 1:20 and the committee has not had a break. So I think we have 4 more bills to do in public hearing today. Most of them will probably be shorter than this one was, thankfully. But I suggest we take a short lunch break now. Let's see, I'm getting some information here. I think we should take a break. And because we've been going for 2 hours and 20 minutes. So I'm going to say, let's take a little less than a half-hour break, a 25-minute break, and be back at 1:45 and see if we can get through these others. And I've got to tell our sponsors what's going on. Senator Stewart, I hope that works for you.
So would it make sense, Madam Chair, for me, so class starts in 30 seconds for me, so I got a jet for that. Would it make sense to, I have 2 bills that are up, would it make sense to just let you guys do the other ones and then come back and do both of them at that point, or?
Yes, I think that makes sense.
Cool. Super. All right. Thank you very much.
All right. Thank you. And if we get through the other 2 before your class is over, we may have to call on you to step out of class,
Sure.
at least briefly.
Sounds good. Thanks.
Thank you very much. Okay, see you all back here in 25 minutes at 1:15. Could members of the committee please turn on their cameras and come back into the panel if you're joining us? Representative Matheson, are you there? Or Representative Blyer? Yep. If you're still eating, I understand if your camera's off. That was a pretty quick lunch for us. Representative Blyer, are you there? I have 5 committee members present. Representative, oh, thank you, Representative Blyer. Representative Arford, are you there? I'm going to give it about 2 more minutes to see if we get any other members of the committee coming in. We don't need a quorum to proceed, but still seems like, there's Representative Arford. We should probably wait a few more minutes to see if anyone else is joining us. I know that Representative Melorano's struggling with her Zoom, I believe, or her computer. Okay. Okay, I'm going to go ahead and get started since there are a fair number of us here now. I'm going to open a hearing on Representative Ben Collins' bill 1281, an act to prohibit discriminatory practices in certain health insurance policies. And if I made an error this morning, I apologize. I got a little confused about the 2 bills we're holding to the end for Senator Stewart. So the order from here on out will be 1281, 1317, 1268, and then 1331. So apologies if I got that incorrect earlier. Whereas Speaker would say the chair was in error. And I will call on Representative Collins to present his bill. Welcome, Representative Collins. I know your internet is sometimes dicey, so if you just want to use audio, that is fine.
Good afternoon. Can you hear me, Representative Tepler?
Yes, I can. Welcome.
Okay, because thank you. I was on the video and my Wi-Fi is very strong, so I don't know where the problem is, but my Wi-Fi is completely fine and the video just disappeared, but I guess you can hear me now. But I don't even have the option anymore to be on video. I don't know what happened. Anyway, I am Representative Benjamin Collins, and I represent House District 42, which is part of Portland. And evidently you can't see me at the moment for some reason, but it really is me here behind the camera. I don't know if you've all received it. I sent late afternoon to the committee a amendment, and I hope that the committee members have that amendment for this bill before them. Did you receive that, Madam Chair?
It is in our document queue, so it is there. Thank you.
Okay, good. Okay, good. Thank you. Yes, so
I don't know if it was distributed to the interested parties list. We can ask Ms. McCarthy-Reed that. Ms. McCarthy-Reed, was the amendment distributed to the interested parties list?
Yes, it was. And I just put the link in the chat for the committee members if you wanted to link to the amendment. It was sent to the interest parties list, and it's also in the electronic committee file for the bill.
Yes, that's what I'm looking at. Thank you so much, Ms. McCarthy-Reed. And I will say to anyone who's testifying on this bill, we would appreciate testimony on the amendment and not on the original bill. Thank you. Go ahead.
Okay. Thank you for that confirmation. Yes, thank you for that confirmation, Representative Tepler. So basically, real quick here, there is an amendment, and I'll really get to that here in a minute. And I'll just real quickly say that this issue about employee excess benefit insurance, or what in the industry or within the committee you would commonly say as stop loss, that basically protects against catastrophic care. And this is for employers that choose to self-insure or self-fund. And in essence, it serves as a reimbursement mechanism for claims exceeding a predetermined threshold. And I was on this committee on the 128th legislature, and I do recall this being an issue back then. And at the time, the chairman, Lawrence, Mark Lawrence, who's now Senator Lawrence, presented a bill to deal with an issue here regarding the stop loss policies. What you saw, this used to be for larger employers offering this, but a lot of smaller employers started to offer this, post Affordable Care Act. And one of the reasons I really wanted to continue to bring legislation forward on this, kind of in the spirit of Representative Lawrence, or now Senator Lawrence did, was I have a great concern about discrimination that can happen in these policies for the group, for the small group. And I will say that over the past few sessions, the legislature and the administration has always found issue, or they think there's issues, and they're greatly concerned about where the small group markets are heading. So my reason for, again, proposing this has concerns about discrimination in there. And when you have a small group, maybe let's say I was a baker, I had a little bakery company, and let's say I had 10 employees, and I offered the stop loss policy as a way to offer some coverage to my workers, which would be, again, more like catastrophic care coverage for them. But it was something basic I could offer them as a competitive tool to hire these workers in a competitive, market for employees. If after a couple of years offering this, some of the members that on my staff had some pre-existing conditions, or they had some illnesses that made my whole pool of employees at a higher risk, the next time I could be denied, the whole group could be denied based on the factors impacting members of my employment, my staff. And so that's a great concern for me, which I know that this committee, this legislature, the Superintendent Chapa's staff has tried to address, but can't address completely. I know they've made measures to try to get there, but that remains a concern. That's why I brought the bill forward. But with that in mind, there is an amendment, and let's talk about that. And I know, in sake of time, myself and everyone speaking after me can focus on that. And after already many hours of hearings for this committee, I don't want to go on and on the history. And I know some of you are much more articulate on this matter because you've worked on it for consecutive sessions, sitting on this committee, specifically Senator Sanborn and some other members. So what this amendment is asking the committee to do, and specifically the superintendent, is to some annual reporting. We know that there's a great concern about the future viability of small group plans. And so we want to be able to kind of curb that and make sure that they don't continue to go away, and that there are less options for people working at smaller companies in Maine. I believe rule changes to kind of address this. You all can correct me if I'm wrong, but I thought it was defined at 10 or smaller can offer, I mean, that you can't, that was a threshold, was 10 employees for offering this plan. If it's smaller than that, I don't believe they're allowed to do so. And so what this proposal would be for the smaller group plans is that we would ask for reporting. I don't know if you all have the amendment before you, but it would ask annually that the superintendent, who currently is Superintendent Chapa, who I've always thought has done a great job reporting and working with this committee and the legislature. So I think his staff would be doing a good service to report this to you, to find out, not just with stop loss, but in general, what are the trends driving employers? Are they being forced out due to issues of risk in their pool? Are there other factors? But I think we really need to get to the bottom of this, as it is a great concern. So as the amendment shows, you'll see the members of the committee that have this before them, or any interested party on this bill that had this email to them and are looking at it, or you see it on the link that just was described by the analyst, Miss Colleen Reed McCarthy. You'll see that it basically is asking for annual reporting on the total number of employers in Maine covered during the calendar year, the total number of small employers in Maine covered during that calendar year, the number of eligible employees, and the number of enrolled employees in each small group. Further asked to report on trends in small group market participation related to standardized plan design, such as clear choice, changes in participation in the regulated small group market, dealing with non-state regulated plans, including excess benefit plans, a study on the impact on the small group market of changing the definition of small group as employers with 2 to 99 employees and 2 to 75 employees, the number of employees as compared to the number of employees enrolled in the offered health insurance plan, and analysis that should be conducted on the above demographics, including gender and geography, to ultimately provide analysis of the impact on changing the definition of small group, some language about a carrier offering these plans, filing reports with the superintendent with certain characteristics, including premium increases over 20%, and other characteristics like that that are offered in this amendment, which I'm sure your analyst can go over. I'm sure the superintendent can talk about this, and we can all discuss at greater length in a work session. In summary, to the members of this committee, to deal with my concern about discrimination in these plans, and knowing that it's a complex matter and it's something that we're working on, I think that a way to deal with this without dragging this bill on over this year and potentially being carried over to next year, I'm asking us to focus on a report where we can actually get the data, we can actually get the facts, and focus on what's before us that's driving a decline in these plans, these small group plans, and to see if we can curb any of that with action. And so I'm foregoing the bill to really sink some teeth into stopping discrimination of certain people that are in plans and making those plans be removed from the market, which would only cause them to be going back into the full insured market, which could provide volatility and cause rates to go up for everyone, and just further cause more instability. I'm taking that away and just simply offering a simple amendment that asks the superintendent to report on some of these trends, so we really can work together to try to put a stop to a big increase in the number of small market plans that are being removed from the market. We obviously want people that are working at smaller Maine businesses to have insurance, and we want to work with the legislature and the administration to find the adequate solutions to deal with that. So I'd be happy to answer any questions. Of course, there are other people that are much more knowledgeable about this issue, much more knowledgeable about insurance policies than I am, who can answer in greater detail. With that in mind, I will end my summarizing of this amendment and ask for you to kindly work with me moving forward onto the work session. If you do have any questions that you really want me to answer, I'd be happy to do so. Thank you very much.
Thank you, Representative Collins. Before I move on to questions from other members of the committee, I just want to ask if you are aware that this committee has approved a 1332 waiver moving forward that would combine our small group and individual markets.
I don't know all the details around that. So I was not fully aware. Okay.
Thank you. I think that's going to play into sort of how we deal with this bill and some of our concerns. But I'm going to turn to Representative Evans, who has a question for you.
Thank you, Madam Chair. Thanks, Representative Collins, for bringing this forward. I think what I'm hearing you say is that you would prefer that we looked at the amendment as opposed to the original resolution.
Yes, I'm thinking that that would be a more expeditious route. And instead of going through this, I'm sure that the analysts can help you and the superintendent get those on this committee who haven't dealt with this issue in the past, to get through some of the complexities and the technicalities of these type of plans and what the issues were in the past, and some rule changes that tried to address this, but not fully. Some issues on discriminating against certain individuals in a small group plan that may cause the whole plan to go away and send people back in the fully insured market. So I think it would be better for the committee and better for these employers and employees if we focus just on kind of getting another refresher, some more data, some analysis from the very capable staff members at Superintendent Choppa's office. And with that, you could more greatly assess what can be done to try to curb the, the exiting of these small group plans due to different factors, which include the stop loss issues, but also may include many other factors.
Thank you.
Thank you, sir.
And Representative Collins, can you be more clear as we move forward about what exactly you mean by discrimination? I'm hearing you say discrimination, but I think you're referring to age, geographic region, smoking, and those things on which health insurance is legal to be rated. Is that correct?
To some extent, yes, Representative Tepler. I believe there would be something that you could look at certain factors such as smoking and other factors that are brought upon by a member of one of these plans within the pool of that employer's offering. It might be something like HIV or something else. So it might be other factors where they wouldn't take the one individual member and say, you can have a plan, but not this individual. But it would take the trends of one or two or more individuals that work at a place and take that into consideration if they would offer the whole plan, if it was too much of a risk. And that was a great concern of mine and of many others in the legislature in the past. And my original bill sought to really deal with that. But I just know my instincts on this moving forward with this committee and with the administration and other stakeholders was that this can get complex and drag out, and in sake of trying to not have this go where it's gone in past sessions, I just thought maybe if we could actually study and get some answers on really what's going on with these markets, how many of these small group plans are being denied, which would then, cause those individuals that have those conditions to be discriminated against. Yes, that it kind of indirectly goes to that.
Okay. Thank you for that explanation. And now I'll turn to those who wish to testify in favor of the bill. And first up would be Kimberly Cook of Community Health Options. Ms. Cook. There she is. Welcome, Ms. Cook.
Thank you, Representative Tepler, Senator Sanborn, members of the committee. I'm Kim Cook, and I'm here on behalf of Community Health Options in support of this bill, really in support of the sponsors' amendment that was we saw last night that would call for a study rather than specific statutory changes. So as a number of you are aware and have been on the committee for a few sessions, we've seen variations of this bill regarding what we call in the self-insured small group market, the stop loss market, and talking about the problems with the death spiral at this point that the small group fully insured market has been in, and essentially trying to understand the factors that are at play and understand the policy levers that can be used by the legislature and the Bureau to ensure that small businesses and their employees have access to quality health insurance, fully regulated health insurance for small employers and their employees. So you've seen it in a number of versions, some of you, and now we're seeing this one, and I commend Representative Collins for taking this approach to really look at, have the Bureau take a look and report back to you on the factors and the information that they can gather about what's going on in the small group market. And so we're here today to support that effort. We would make a couple of suggestions if the committee were inclined to move forward with this, which we hope you do. One would be to ask the Bureau to begin doing their reporting to the committee in 2022. I think it says February, but it doesn't say a year. So that way you would begin next year looking at some of the factors that are have caused the small group market to decline in size and increase in price, mainly because, of course, it's a smaller and less healthy population that's been left in the small group market over the years. And also that in subsection 5 of the revised bill, which deals with changes in participation in the regulated small group market, we would ask you all to consider including changes in demographics in that sections, in particular about age and geography, to fully inform your policy making in the future. We also don't see this as inconsistent with the Bureau's with the bill that you passed that allowed the Bureau to go forward with merging the markets, assuming certain guardrails are met. That process is ongoing. This I don't see at all as inconsistent with that approach. And so they're not mutually exclusive. Thank you very much, and I'd be happy to answer your questions.
Thank you for your testimony, Ms. Cook. I am looking to see if any member of the committee has any questions for you. I'm not seeing any. I thank you for your testimony. And next up is Kate Endy. Ms. Endy.
Good afternoon, Representative Tepler, Senator Sanborn, and members of the committee. My name is Kate Endy. I'm Policy Director of Consumers for Affordable Healthcare. It's nice to see you all again. I will keep my comments brief. We share many of the concerns that Ms. Cook and Representative Collins have outlined already, in that the more small group plans that choose to self-insure, which predominantly would seek stop loss insurance, that pulls out employers and from the small group market that's fully funded, fully regulated. And so not only do they not have to follow all of the same rating practices, but most of the consumer protections that you all work so hard to put in place for the state of Maine largely apply to fully funded plans. And so, when we think of, the protections passed for surprise billing, let's say, from last session, those don't apply to people in self-funded plans unless that plan elects to follow those rules. So for the reasons outlined by others concerning the increases in premiums in the small group market, which have been extremely high the past several years, in order to make sure that coverage is affordable for small employers, we would support studying the impact of stop loss insurance and the small group market and what that has had in Maine. I'll just note that other states, for example, DC, have heavily regulated stop loss insurance in their state in terms of what is available to small group plans. But I'm happy to answer any questions. Thank you.
Thank you very much, Ms. Endy. And any questions from the committee for Ms. Endy? No? Seeing none, is there anyone else in the attendee list who would like to speak for the bill, in favor of the bill? Okay, Ms. Erin Bowles-Welsh. We'll have you come in next to speak in favor of the bill. And when we go to those against the bill, we will be switching chairs. Oops. We can see you, but you're muted, Ms.
Okay, thank you. All right, sorry, my computer chose that time to freeze, so perfect timing. But good afternoon, Senator Sanborn, Representative Tepler, members of the committee. Thank you for the opportunity to speak this afternoon on the amendment presented to LD 1281. My name is Erin Bowles-Welsh, and I work for Harvard Pilgrim Healthcare. As you know, Harvard Pilgrim Healthcare is a not-for-profit health services company. We've now joined with Tufts Health Plan, another not-for-profit health services company. And we now serve 2.4 million members throughout New England. And as you also know, we are a leading health insurance carrier in Maine for businesses and individuals, including thousands of small employers in the state, the topic of today's testimony. Harvard Pilgrim has been before this committee several times over the past few years to discuss concerns relative to proposed changes to and trends in Maine's small group market. The issue most recently came up during a hearing in February on clear choice plans and the potential merger of the small and individual insurance markets. During the hearing, the small group market was referred to as in a death spiral. Whether we would use those same words to characterize the changes we observe or not, we testified today on the amended language to LD 1281 aimed at being responsive to those discussions, to acknowledge the delay of the merger of the small and individual markets, and to be solution focused. And in the spirit of identifying trends in fully insured small group market participation and the policy levers influencing those trends. As has been briefly laid out, the bill as amended requires the Bureau of Insurance to study the small group market as related to participation in the fully insured insurance market, small group participation in alternative insurance options, such as stop-loss plans that operate outside of the Affordable Care Act, the interaction between the fully insured and self-insured small group markets, and analysis of the proposed and future policy changes, including standardized plan designs on the small group market long-term. Annual bureau and carrier reporting is also required and expanded beyond previous reporting requirements on similar topics. As you know, we are a dedicated health plan supporting Maine small businesses and their employees. We're committed to providing the best health insurance coverage at the greatest value in the market. And we believe that a robust, fully insured small group market guided by ACA protections are critical to residents of Maine. And we believe that a comprehensive study of the market and all of the levers influencing it is an important picture to have for all of us as decisions are made moving forward to ensure the long-term success of the small group market and value to small employers. So I appreciate your time and the opportunity to speak on the amended language. And I hope for committee support for this. And I'm happy to answer any questions that you might have.
Thank you, Ms. Welsh. Oops. Yeah, no, I am on. Sorry. Thank you, Ms. Welsh. And are there any questions from the committee for Ms. Welsh? Seeing none, thank you for your testimony. And I will step away from the gavel, as it were, and turn it over to Senator Sanborn.
Thank you, Representative Tepler, and thanks to the committee for your patience as we negotiate some busy days and multiple bookings here. Next, we will hear from Superintendent Chapa.
Good afternoon, Senator Sanborn, Representative Tepler. I'm not going to read my testimony because that's based on the original bill, and we're no longer in opposition. We're neither for nor against. We're still evaluating the amendment. But a couple of things I'd like to point out. We did adopt a rule on excess insurance, Chapter 135, and we do prohibit lasering, which is a specific excluding of a singular employee when the underlying benefit plan covers it. And we do prohibit self-insurance for those 10 or fewer employees. And we made this attachment point at 28,007. And finally, the data, the most recent data, which is still in draft form, shows the number of small groups actually decreased, but it went from 511 to 510. So it's really not proper to call it a decrease. It was flat. But the number of enrolled employees is went from 7,599 to 7,950. So that gives you a context of what size of the market we're talking about. About 500 employers and less than 8,000 employees are covered by the small group excess, and that's eligible employees up to 50. So that's the entire market. So that's the context. But having said that, I very much appreciate Representative Collins reaching out to us, and we'll continue to work with them on the amendment, and I'll be happy to answer any questions.
Superintendent, can you clarify for us whether there's any items in the amendment that we aren't already receiving a report about?
Well, at first glance, there are. I mean, like gender, you can't rate for. That's already illegal, and that's in there. So that's one. And there's some that appear that you can only get from the employers. Let me see if I can. I'll have to answer that more thoroughly at the work session. It's escaping me now. And like this, we're not collecting the study of this changing the definition of small group to 2 to 99 or 2 to 75. That obviously is new. So again, we're just reviewing data elements now. We just got these late last night, and we're still doing. But But you're,
But as far as the employee benefit excess insurance, didn't we ask you guys to study that last session and start
we actually have
collecting
an
that
annual-
data?
Yeah, we actually have an annual report, and the 2021 is just about ready. I have it in front of me, and you got one last year.
Right.
It has most of the data required, but not all of it. So there are some additional elements that we would need to add, but so hopefully by the work session, the 2021 report will be ready.
Okay. Yeah, that would be very helpful, Superintendent, because I think the trends don't, from what I'm understanding, the trends aren't actually upward in that particular
I don't believe so.
product. Okay. Very helpful. Are there other questions for the superintendent? All right, seeing none, thanks for providing that context for us. Next, we will hear from Christine Ossenfort. Good afternoon, Ms. Ossenfort, go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenfort. I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland. And I was originally planning to testify in opposition to LD 1281 as it was drafted. Excuse me, as it was drafted. As the committee knows, this issue has been taken up a number of times, and the bill as drafted would effectively eliminate an option for small group plans. With respect to the proposed study amendment, like the Bureau, we are still reviewing what would be required. And as Senator Sanborn noted, we also questioned how much of this isn't already available. The small group stop loss rule does require us to report certain information to the Bureau. So with that, we will review it. We will provide you with our comments before your work session, and I'd be happy to answer any questions that you might have.
Thank you, Ms. Ossenfort. Are there questions for Ms. Ossenfort? All right, seeing none, thanks for being here. Next, we'll hear from Dan Riley. Good afternoon, Mr. Riley. You can unmute and go ahead.
Senator?
Yes, now we can hear you. Go ahead. Now we
Okay,
can see you. Go ahead.
fully loaded here. Thank you very much, Senator Sanborn, Representative Tepler, and members of the committee. My name is Dan Riley. I'm an attorney with a firm of Norman Hanson Troy in Portland. I'm here this afternoon representing our client, Aetna, a CVS company, in opposition to the original bill, but I'll focus my comments to the amendment. For essentially what I want to cover with you today is first, that the veterans on this committee have a lot of experience with this issue, as has already been raised by a number of different people. But for the new members of the committee, this is a case of first impression for many of you. And so what I would recommend is that you take a look at Chapter 135, the rule that Superintendent Chapa described to you or made reference to earlier. That rule became effective on September 18th of 2019, and Section 7 of that rule provides for a reporting mechanism. And in the basis statements and comments on the rule, the Bureau of Insurance categorized those reporting obligations as a robust set of reporting requirements. So I think Senator Sanborn made reference to the fact that you have a number of reports coming to you, but this particular report from Chapter 135, which the superintendent said is scheduled to be submitted to you actually this month. Under the rule, it's to be submitted in April. That's going to provide you with a lot of information about this. issue that has been before this committee now in different iterations over the course of the last 5 years. So for those of you trying to get up to speed on the issue, the basis statement and comments from the Chapter 135 rule will help significantly to give you some background on this issue. And with that, I'll just close my testimony saying that I believe that Chapter 7 of, Section 7 of Chapter 135 provides the Bureau with the authority to do much of what Representative Collins is looking for here. With that, I'm happy to answer any questions you may have.
Thank you, Mr. Riley. I don't know if you said this at the top of your testimony, but I missed it. If you did, can you let us know who you're here on behalf of?
Yes, I did. I mentioned that I'm representing Aetna CVS Company. And
Perfect, thank you.
My written testimony, which was submitted yesterday, makes specific reference to that.
Yeah, okay, great. Thanks. Are there any other questions for Mr. Riley? All right, seeing none, thanks for joining us. Next, we'll hear from Charlie Sultan.
Thank you, Senator Sanborn and members of the committee. My name is Charlie Sultan, and I am here on behalf of Cigna Healthcare. Much of what I had to say has been said. We were in opposition to the original bill. I was about to press the send button on my written testimony and then the amendment came out, so I didn't push send. And we'll try and rejigger that. As to the amendment, as others have said, the current rule, Chapter 135, covers a lot of this. This is the third attempt in 4 years to deal with this issue. We believe that the rule, which was heavily discussed through stakeholder groups before it was published and then adopted, goes a long way in answering a lot of the questions, as well as the reporting requirements under Section 7 of it. We would continue to impose adding what I think is a very different issue about changing the size of what a small group market is and who qualifies. That's a very different public policy, and we would urge you not to go down that road at this time. So we believe for that reason that what is already required and what the superintendent just talked about reporting to you shortly will give you a really good indication of what's going on in that marketplace. Stop loss is important. I'll let you look at the written testimony and all the other testimony that's been given over the years, but with time short, I will leave it at that and urge you to still do an ought not to pass and rely on what's already happening. Thanks.
Thank you, Mr. Sultan. Are there questions for Mr. Sultan? All right, seeing none, thanks for joining us this afternoon. So that reaches the end of the list of participants who had registered in advance to speak on this bill. If you had intended to give oral testimony on this bill, please raise your hand at this time and you'll be recognized. All right, seeing none, I'll bring the hearing on LD 1281 to a close, and work sessions will be scheduled likely for next week on that bill. So with that, I think the next bill we're going to pick up is LD 1317. So we'll open a hearing on LD 1317 by asking our own Senator Brenner to present her bill.
All right. Good afternoon, everyone. Senator Sanborn, Representative Tepler, and honorable colleagues of the Health Coverage Insurance and Financial Services Committee. I'm Stacy Brenner, and I represent Senate District 30, which includes Gorham, most of Scarborough, and part of Buxton. And I'm here today to introduce LD 1317, an act to regulate insurance carrier concurrent prepayment and post-payment review. I was asked to introduce this bill by the main chapter of the American Physical Therapy Association after at least 3 of their members were subjected to prepayment reviews by an insurance company, and the process put them at risk of losing their 20-plus-year-old businesses. These are all in-network quality providers who are leaders in their profession. I know that because I've referred pregnant and postpartum patients to at least one of these practices from my own midwifery practice over the years. This bill would set up guidelines for when insurance carriers perform audits and reviews, such as prepayment review, of a provider's documentation and records. While these providers had issues with the prepayment review process, the bill applies to all forms of medical record reviews: concurrent, while treatment is in progress; retrospective, which are done after payment has been made; and prepayment, reviews been performed after the service is provided, but before payment is made. I want to first tell you what this bill will not do. It would not stop a carrier from doing their due diligence to root out fraud, waste, or abuse. And I'm willing to work with the carriers if they think the provisions in this bill will interfere with their ability to do that. But what we are seeing is good providers whose audits proved they were not committing fraud, waste, or abuse that are still being put on prepayment review for minor documentation errors or omissions. And this is the situation that we're trying to fix. I will not go through every provision in this bill in my testimony today, but overall, this bill attempts to make the prepayment review process fairer for our small, locally owned healthcare providers that are so critical to our communities across Maine. This is particularly important for allowing the growth and development of healthcare services by independent practitioners in rural communities. The bill streamlines the review process, requires that providers have the ability to submit documentation electronically, allows for appeals, and ensures claims will be dealt with in a more timely fashion. I've been in conversation with the industry and the Bureau regarding amendments to the bill that will help make the legislation clear and effective at achieving the goal while addressing the concerns raised by the Bureau. We are committed to working together in advance of the work session to deliver a bill that elucidates roles, responsibilities, and procedures. I want to reiterate that the providers you'll be hearing from today who have had experiences with prepayment review are not afraid of being reviewed. They are afraid of unfair reviews or reviews that delay payments to the point of putting their businesses at risk. The review process is a necessary one, but we should not allow it to push businesses to the brink of failure. Thank you for your time. I would be happy to try and answer any questions that you might have at this time, but I do believe that your questions are best directed at those that are coming after me who have a closer relationship to the problem. Thank you.
Thank you, Senator Brenner. Are there questions for the bill sponsor? All right, seeing none, we thank you for bringing us this bill. And next we'll hear testimony in favor of the bill. I will be using a 3-minute clock, as is our custom. And so first I will call on Gwen Simons. Good morning, Ms. Simons. Good afternoon, Ms. Simons. Go ahead.
Senator Sanborn, Representative Tepler, and members of the committee. I'm Gwen Simons, a resident of Scarborough and the lobbyist for the Maine chapter of the American Physical Therapy Association, which represents our licensed PTs and PT assistants in Maine. And we are the proponents of LD 1317. As Senator Brenner said, we brought this bill forward specifically to address problems our PTs and other providers were having. You're going to hear their compelling testimony today. Our national association, APTA, also has been concerned about the growing problems with audits, recoupments, and repayment review processes across the country. And I've included a support letter for our bill from APTA in your packet along with my written testimony, which I'm going to try to cut short. We are concerned that if some of these problems are not resolved, that the providers will start to go out of business or out of network, and neither of which is good for consumers or controlling healthcare costs. The bill is very long, so I've submitted a document with my testimony that goes over our rationale for each position. Senator Brenner mentioned some of the main things that the bill does, so I want to focus my comments on the amendments that will be forthcoming. As she said, we've been in communication with the Bureau about their concerns, which were primarily that the bill might expand patient appeal rights or give providers appeal rights under Rule 850. That is not our intent, so we will be making amendments to sections G and J and completely deleting section L in its entirety to make that intent clear. After we have made those amendments, we don't expect this bill to create any additional burdens for the Bureau or for the bill to have a fiscal note. We also will be amending section D by replacing the reference to Medicare documentations with a simple reference to professional standards of the professional association of the provider that is being reviewed. And that's because professional associations are in the best position to determine what the profession's documentation standards should be. To be clear, this bill is intended to establish laws that regulate the provider-carrier contract. That does not mean we expect the Bureau to regulate that relationship. What it means is that the provisions that we intend to pass in this law will give the providers a cause of action for any legal dispute that should arise under their provider-carrier agreement if the carrier violates this new law. And if that should happen, then the methods of resolving those disputes will still be in accordance with the dispute resolution clauses in the provider agreements. There are already numerous main laws already in existence that regulate the provider-carrier agreement, including laws that require prompt payment, require termination of providers, regulate the termination of providers from carrier networks.
Simons, could you wrap up?
Sure. So anyway, those laws already exist. So, and including some recent laws passed for pharmacy providers, which are actually on the same issues that we're attempting to address in 1317. So we will continue to work with the Bureau. We're willing to work with the carriers on any concerns they have. We thank you in advance for your consideration, and I'm available to answer any questions that you have.
Thank you, Ms. Simons. Are there questions for Ms. Simons? So I'll ask you one, and maybe someone coming behind you might be better to answer it, in which case I'll let that go. But this was an issue that I was unfamiliar with when I first spoke with you about it a few months ago. So it's not something our committee has really dealt with in the past. Can you just sort of give us like a step-by-step of what this prepayment review audit thing feels like, or how it works? Because it's not something that we have really heard testimony on ever before from anybody.
Yeah, that's a really good question, Senator Sanborn, because this problem is not new. It's actually been happening across the country. I think it's just late to get to Maine. There have actually been some class action lawsuits over the last 10 years that have attempted to address this problem with varying outcomes. So we became alarmed when our providers here in Maine started experiencing this problem. Essentially, for whatever reasons, the provider is usually not told how they are targeted for review, but they're requested to send in a sampling of their documentation for an audit. The documentation is reviewed, presumably under a assumption that the carrier is looking for fraud, waste, or abuse because of where the audit request is coming from. The audit turns out that there is no fraud, waste, or abuse, but still, for whatever reasons, the carrier puts the provider on prepayment review, meaning all of their records are going to, or are supposed to, presumably get a review by someone. We don't know the qualifications of that person to determine whether the claim meets the conditions of payment, that it's medically necessary, that it's a covered benefit, et cetera. But what we were seeing from the providers who have been reviewed, and you're going to hear more about their experiences in a minute, is the criteria that was being used to deny the claims that were reviewed were really not about medical necessity or whether the right code was billed. Sometimes they were about minor documentation errors or omissions, and quite frequently about disputable errors or omissions where the carrier thought there was something missing, but the provider did not. And the provider had no opportunity to appeal, even being put on prepayment review. Once they were put on prepayment review, they had to mail their documentation along with their claims in by snail mail to a PO box where the claims were either lost or claimed to have never been received, which delayed the adjudication of the claims in the first place. And then when the claims were adjudicated, what we believe a lot of times was arbitrarily denied, with just a statement on an EOB that would say documentation missing. Well, when the provider would call and say, what is missing? We sent everything to you. They would find out that the documentation was actually there, or the documentation was scanned in incorrectly by the carrier, so there was a page missing, or no one could tell the provider what documentation was missing at all. So there's a real disconnect in the procedures, and the providers and therapists getting the information they need to send the proper documentation to the carrier if they claim something's missing.
Thank you.
So,
I think that gives
yeah.
us a good flavor of what we're talking about here. And then can you speak to what types of practitioners you're aware of have been subjected to this type of prepayment review in Maine?
Yes, it's been private practice, physical therapists, chiropractors, and acupuncturists. To my knowledge, I don't know of any others. I have talked with Jeff Austin, who I don't know if he's on the call or not. He was not aware of hospitals experiencing that issue, but I believe that he's going to submit some written testimony about their position on the bill as well.
Okay. Thank you very much. Representative Evans, go ahead.
Thank you, Madam Chair, and thank you, Ms. Simons, for bringing this forward. This, I tend to agree, this is a problem. My question is, normally, shouldn't this whole process be resolved within 30 days? It should be resolved in 30 days. And I'm also hearing that it's going well beyond that. Do you have an average length of time that people are spending on chasing this paperwork?
Yes, the providers who are going to testify are going to give you specifically their data from their experience. What we're hearing is on an average of no less than 9 months up to a year to get claims resolved. Some claims are taking 2 years, and that goes straight to the issue that some of the other bills that you've heard are trying to fix that problem of the providers can't bill the patients until these claims get adjudicated. So the patients are getting bills much later than they should be. And it's interfering with their ability to use their health reimbursement accounts and flexible spending account money.
Thank you.
Ms. Simons. Are there any other questions for Ms. Simons? All right, seeing none, thanks for bringing us this important issue. Next, we'll hear from Robert Reed. Good afternoon, Mr. Reed. You can go ahead.
Good afternoon. I assume you can hear me.
We can. Go ahead.
To the chairs, members of the committee, and the legislative staff, my gratitude for allowing my testimony on the bill before you. My name is Robert Reed. I'm the executive director of the Maine Chiropractic Association. My testimony today is in support of the bill before you and will speak to the why the bill has been submitted for consideration. You'll hear testimony today from several healthcare providers in different fields, all with the same concern, that insurance carriers hide behind various layers of rules and policies unknown to the health provider community, rules which impede reimbursement for appropriate services rendered. You will also hear the reimbursement being held or denied for internal review systems and of claims being denied without explanation, all in the name of wanting to fight fraud and abuse. Worst of all, you'll learn of people hired to do the reviews who are not trained to even understand the type of healthcare professional they're reviewing, instead relying on algorithms and internal policies which require reviews based on statistical data only. You'll also likely hear from insurance carriers explaining that their efforts to review claims are to ensure the best spending of the healthcare dollars. But is it? You as a committee can require the carriers to provide the same level of explanation as Medicare does on a national level. Make it transparent to all involved exactly when a claim might be reviewed through open policies, which clearly outline the steps and details as well as the reasoning behind the question. You also have the ability through this bill to ensure that any review is done by people trained to do so and who understand what they are reviewing. I've had the good fortune of working with a carrier here in Maine, as well as with Medicaid folks, to change how reviews are done and to allow local doctors of the same specialty to be involved with either the training or the review process. And in one case, to actually be part of that review team. This has led to better results while ensuring that healthcare dollars are being spent appropriately, both in the claims reimbursement and in the internal costs of the reviews. I'm happy to answer any questions, although I suspect the healthcare providers following me will be able to give you much better examples. I thank you for your time and look forward to your questions.
Thank you, Mr. Reed. Are there questions for Mr. Reed? All right, seeing none, thank you for your testimony today. Next, we will hear from John Charlebois, if he's with us. Dr. Charlebois, go ahead. We can't hear you yet. There we are. Go ahead.
Thank you, Senator Sanborn, Representative Templer, and members of the committee. I'm John Charlebois, co-owner and president of Jade Integrated Health. I'm a licensed acupuncturist. I raise a family in Cape Elizabeth, and I own offices in Portland and Brunswick. Thank you, Senator Brenner, for sponsoring this bill. This is an important issue that affects healthcare practices and patient access to care across Maine. My wife and I opened Jade Integrated Health 20 years ago. We are an independent family practice employing 20 people focused on evidence-based, high-quality care. In other words, we are experts in our field and build relationships with our patients to ensure that we understand and treat the whole person. Our practice has grown quickly because patients get better faster and stay well longer. This model reduces healthcare costs while restoring individuals' lives and livelihoods. All around, it's a win-win. This is typical for small family practices where we do not see our patients as simply a business proposition. However, it also means that our margins are thin compared to large corporate practices and hospital systems. Prepayment review and other programs like it may destroy this effective model. When insurers like Anthem put practices like ours in prepayment review, they set arbitrary standards throughout the process, and we are not able to stand up against these unfair practices. For example, we were on prepayment review for 10 months. We were not getting paid for most of the care we were providing to Anthem patients. This represents 45 to 55% of our business because of the large market share they possess. At that time, we continued to pay our employees, including employees that schedule patients, provide care, and billers that bill for our services rendered. Therefore, we had no financial staffing resources to go up against Anthem to dispute their unfair withholding of our payments for services rendered. In fact, our prepayment review, we had to hire an additional full-time billing specialist. The process of prepayment review literally added more than 40 hours a week of administrative burden. Over the course of prepayment review, it cost our company approximately $1,500 in just printing and mailing expenses, and over $80,000 in billing employees' wages to date. Through this whole process, we had 781 claims total on prepayment review, and only 441 of them have been paid to date. We continue to have 266 claims that we are trying to get paid from the prepayment review process. We have submitted 209 claims to the appeals process. 139 have
Thank you, Mr. Charlebois. Can you wrap it up for me?
Leaders in Maine often talk about the importance of job creation and that businesses like Jade are the backbone of the economy. Processes like PPR puts jobs and economies at risk. Not only we at risk, but needing to cut staff due to lack of income also forces us to put question on whether we can expand and provide more job opportunities. This process was so burdensome that an employee of ours for 4 years and a beloved part of our team could no longer do the job.
Can you wrap up for us? At
And
this point, we're over the 3 minutes.
Thank you very much. I'm ready to take questions or answer any comments that the committee has.
Okay, thank you. Are there questions or, questions for Mr. Charlebois? All right, seeing none, we thank you for being with us today. Next, we'll hear from Gregory Fox. Good afternoon, Mr. Fox. Please go
Hi,
ahead.
good afternoon. I'm starting my video and
Great, we can hear you. Yep, go ahead.
Great, thank you. Hi, good afternoon. To speak to Senator Sanborn, Representative Tepler, and members of the committee in support of LD 1317 today. I'm Gregory Fox. I have submitted written testimony. I hope you're able to see that now. I'm representing myself, my wife, who's a physical therapist, and Heritage Integrative Healthcare with practices in Bridgeton and Falmouth, Maine. I've been in practice for 21 years, in which I've had the pleasure of testifying before this committee on multiple times, including sessions in which we advocated for healthcare cost transparency and legislation barring discriminatory practices. My written testimony is submitted, and I'll keep this brief. In July of 2019, we got a document request from a carrier. It took them more than 6 months to respond to the charts and the claims and the notes and things that we sent. Following the response, we were informed that we were going to be subjected to a carrier's prepayment review until our documentation was deemed satisfactory. In the first days of this PPR, which actually was March of 2020, the very first days of the pandemic, we met with the carrier and their specific role. They have someone who investigates, who's called a certified professional coder. And I found that interesting because I already had a certified professional coder on my staff for the previous 12 years. So it was going to be interesting to see professionals debate on these topics. First, we qualified the documentation was not, and claims for payment were not fraud, waste, or abuse, and the carrier confirmed they were not. Second, we started to ask for a detailed list of procedures and the documentation errors that they believed were outliers. They agreed to provide the list and supposedly had already been aggregated, but then it took them more than 90 more days to provide us with that content. You know, what we saw, myself, our attorney, and my certified coder, what we saw were best described as straw man arguments or biased opinions represented as fact. And so we disagreed with the results of the documentation audit. We disagreed with those strongly. By that time, it had already been announced the prepayment review would begin. And so that's been more than 12 months. As I mentioned, we do have a billing professional who has, reviews our records, makes sure our content is appropriate. And we were strongly convicted that our documentation more than met standards and we were being targeted. Initially, we followed the process for paper submission, and that was fraught with errors. So we immediately, on our own accord, switched back to electronic documentation submission and electronic claim submission so we could prove timely filing.
Thank you, Mr. Fox. Can you wrap it up?
Yep. After 22 months of this, we basically have miraculously given the letter that we've passed our documentation review, and we are no longer in prepayment review. But what I'd like to point out, and this is part of my written testimony, is that we had made edits to our documentation system more than 4 months before any of this began. And they should have known in the first 30 days, as Representative Evans mentioned, they should have known in the first 30 days that our documentation was sufficient. We did not make additional changes to our documentation, and they continued to process denials for more than 12 months. At which time, like I said, we did not make changes to our documentation. We held firm, and then they sent us a letter and said,
okay, your 3 minutes is up. So if you could just wrap it up with a final statement.
Well, thank you, and I appreciate the extraordinary efforts of the committee, their dedication to improving healthcare. I'm open for questions from anyone at this time. Thank you.
Thank you, Dr. Fox. Are there questions for Dr. Fox? All right, seeing none, thank you for providing testimony to us today. Next, we'll hear from Zev Meyerowitz.
Hello, can everybody hear me?
We can. You can go ahead.
Wonderful. Thank you so much. Senator Sanborn, Representative Tepler, and honorable members of the committee. My name is Dr. Zev Meyerowitz, and I am the Director of Health Services at Cape Integrative Health. We are a 13 provider group located in Cape Elizabeth, Maine, where I additionally reside. CIH offers primary care, physical therapy, chiropractic, and acupuncture services. We have been in operation for over 10 years, and just as a measure of our size, we perform over 30,000 office visits annually. I additionally serve as Vice President of the Maine Chiropractic Association, and my testimony is in support of the bill before you and to speak as to why this is so badly needed. PPR is absolutely a tactic currently abused by local carriers to arbitrarily deny claims and withhold payment under the pretense of improving documentation. In our case, after a series of record requests, we were notified that we were going to be placed into PPR. We were allowed no opportunity to appeal, despite the carrier readily admitting there was no suspicion of medically unnecessary treatment or fraud, waste, and abuse. And I want to point out that after over 7,000 claims that have been submitted, we haven't had a single denial for medical necessity or suspected fraud, waste, and abuse. When an office enters PPR, all facility medical services must be snail mailed to various addresses throughout the country. I believe this intentionally bypasses electronic tracking and is engineered to intentionally create missing claims without culpability on behalf of the insurance company. We process approximately 1,000 PPR claims a month alone, and each claim is approximately 15 to 20 pages long. 1 out of 7 is denied due to scan error rates and mishandling, and we have to resubmit them again. In our case, reports are periodically run by the investigators, and if the office's claims are below that of their private arbitrary fail rates, individual codes remain in PPR until the office improves this calculation and is allowed to exit the process. This rate includes trivial denials that would be eliminated by electronic claim scrubbing, such as having the wrong ID number, a date of birth, or so forth. Denials are extremely nonspecific, and no meaningful information can be gained from denials that generically state missing documentation or not enough information. We currently have hundreds of physical therapy claims that are denied because we use the phrase guided instead of monitored, and that this word somehow was interpreted by the auditors that the patient was not supervised during their procedure. We have had to hire several full-time employees to manually track thousands of paper claims where no communication was received, no explanation of payment was provided, or payments were approved but never actually issued. And this would all be avoided with electronic claim and document uploading. We are 7 months into this process. Our delayed account receivables from just this one carrier results nearly half of our entire gross receipts for 2020. As claims are painstakingly corrected, reprocessed, and appealed via mundane and efficient paper means, we are ultimately paid, but we're 6+ months after the point. And only at that time, as mentioned, can we send invoices to our patients. And while this clearly places undue financial hardship upon any office, I think the patients suffer more because they're prevented from utilizing their health reimbursement accounts for the expenses that they incur. Some of these have very finite deadlines for the previous year. I please ask you to vote ought to pass for LD 1317. I'm happy to answer any questions you have.
Thank you, Dr. Meyerowitz. Are there any questions for Dr. Meyerowitz? All right, seeing none, thank you for your testimony and for keeping it under the 3 minutes. Next, we'll hear from Nancy Charlebois. Good afternoon, Ms. Charlebois. You can go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and honorable members of the committee. My name is Nancy Charlebois, and I live in Cape Elizabeth. I'm a co-owner of Jade Integrated Health with locations in Portland and Brunswick. Thank you for hearing my testimony today. I'm going to speak on the details of PPR, highlighting the specific practices that Anthem employed for the purpose of to not pay small practices like ours. Please reference our written testimony for a more thorough and detailed list of hurdles Anthem put in place for PPR. Some of the practices relevant to Part B of the Act are requiring that all documentation on a patient claim be mailed. Because Anthem took our mailed paper claims and scanned them into their system, critical pieces of patient medical records did not appear because of their scanning errors. What ultimately ended up in Anthem's patient medical record was out of our hands. Relevant to Part E of the Act is not paying claims citing deficiencies not relevant to medical necessities or deficiencies in charting, which included stating that, for example, time in and time out is not documented. The words quote unquote face-to-face were not written in the note. A flow sheet is missing when there was no flow sheet necessary in the medical record. An attachment is required when none was actually needed. Relevance to Part F, G, and K, Anthem does not deny the claims you're submitting, but will only reconsider them. This prevents practices from being able to appeal. This drags the process out for months. They point out perceived deficiencies in the note, and then we send an addended note in order to resolve the perceived shortcoming. However, claims are not reviewed by the same Anthem rep. After addending one claim, another reviewer might cite a technical issue with the same claim and refuse payment. This made it impossible to satisfy Anthem documentation demand and kept us from an appeals process. Relevant to Parts J and K, Anthem started a process they could not manage. They had no process to confirm claims received other than making our billers call Anthem, wait on hold 50 to 60 minutes to ask if specific claims had been received. Depending on who you spoke with, depended on the answer you received. Different departments had different answers. So Anthem was unable to track claims information, and claim perceived deficiencies for the purposes of getting us accurate information and ultimately payment. On more than one occasion, Anthem reps reported that our documentation must not have even been read because the information needed already existed in the note. Relevant to Part H, on a disputed note where I was not the rendering provider, but I read the note and spoke directly with the Anthem rep. There was so much detail in the note that I, not having ever seen this patient, knew their diagnosis, medical history, treatment provided that day, and the patient's response that if needed, I could reproduce that treatment exactly. When I asked for exactly what type of detail was missing, he simply said not enough detail and the claim would not be paid. Finally, relevant to Part I is that due to the copious amounts of claims that we needed to follow up with and the time it took due to Anthem's inefficiencies, we were unable to get paid for many claims because they are now incorrectly applying timely filing limits. Please vote to pass LD 1317.
Thank you very much. Are there questions? Are there questions? All right, seeing none, we thank you for your testimony this afternoon. Are there, let's see, next I'll call on John Royce.
Luckily you can put a lot more in the written. Yeah, right. But you were fast, you got a lot of important points.
Mr. Royce, you can unmute and go ahead.
Can you hear me at this point?
We sure can. Go ahead. Now you've muted yourself. You are currently muted.
Now can you hear me?
Now we can hear you again.
Okay. I'm sorry about that. Senator
That's okay.
Sanborn, Representative Tepler, honorable members of the committee. My name is John Royce, and I am here as a lobbyist for the Maine Chiropractic Association. LD 1317 is legislation that addresses some inequities within the concurrent, prepayment, and post-payment review process. I've been representing the chiropractic profession for many years and have witnessed firsthand some of the problems that are present in the review process. Reviews flag because of very minor or technical issues. Reviewers from out of state that know little of the care doctors of chiropractic provide. We actually had a very similar bill drafted to submit this legislative session, but withdrew ours in order to support this particular bill. Reviews are important to the process, but they should not be abused or used to delay or defer payment. I certainly will be present at the work session, and thank you for your time.
Thank you, Mr. Royce. Are there any questions for Mr. Royce? All right, seeing none, we thank you for being here with us today.
Thank you.
I put up a last call for anyone who wishes to testify in favor of the bill. If you're on our Zoom meeting, please raise your hand at this time. Okay, I'll call on Jean Gore, who raised her hand. Good afternoon. Go ahead.
Good afternoon, Representative Tepler, Senator Sanborn, and the distinguished members of this committee. I'm actually here to testify on another piece of legislation, but I have been sitting here listening to this one and felt compelled to speak up and testify in favor of this. I can give you only my personal experience over the past year. I have been seeing an acupuncturist, Celia Thibodeau, in Springvale at the Gateway of Hope Holistic Healing Center. And I've been seeing her for many years, and they have not paid, I'm guessing, I think we're up to 4. For 4 of my visits, I see her every 6 weeks. The furthest one back is dated January 24th of last year. She and I have both spent many hours, both on the phone and through their patient portal and provider portal, trying to understand why they're not paying. And they tell her that they never received her fax. She faxes it again. They tell me that something was missing in the encoding and that they needed her to resubmit it. So she resubmits it. She waits on hold for hours just to get through to speak to someone. It's never the same person. And as a result of all of this, she tells me that this has happened with so many patients. She's actually retiring. She just can't take it anymore. And she's in, private practice, and she has bills to pay, and she's getting older, and she's just tired of it. And it's devastating for our community. She has helped so many people, including myself. Not sure where I'm going to go now that she's retiring. I can tell you the same thing happened to me with my dentist. Delta Dental, and I don't know if that's completely out of the realm of this discussion, but they have denied paying for my crown for 9 months now, and it just goes back and forth and back and forth. So I am strongly in favor that this ought to pass. Thank you so much.
Thanks for joining us and for testifying in favor of the bill. At this time, we will switch to those who wish to testify in opposition to the bill. First, I'll bring over Superintendent Chapa. Good afternoon, Superintendent. Go ahead.
Good afternoon, Senator Sanborn, Representative Tepler. We were opposed to the original bill. The amendment, I would say we're neither for nor against. We're still reviewing the amendment, but I wouldn't characterize us as opposed. The reason for our initial opposition is we're not unsympathetic to what the providers are saying, but we feel very strongly that the Bureau shouldn't be placed in the middle of provider carrier disputes. And it's similar to the pharmacy provider issue, not similar in its nature, but we raised the same objection and the committee came up with a solution to that. So again, we're still reviewing the amendment, but it goes a long way to addressing our concerns, which was the basis for our opposition. With that, I'll be happy to answer any questions.
Thank you, Superintendent. Can you remind us what solution we came to with regard to pharmacy provider disputes?
Well, at the end of the day, and this is section 4317, you put some guardrails around the audits, but then you required they had a right to mediation at the end of the day over the audit. Again, it's similar, but it's not the same. But conceptually, it started off with the Bureau overseeing the disputes between the pharmacist and the carrier, and this is what the committee came up with as an alternative.
Okay. Great. Are there additional questions for the superintendent? All right, seeing none, thank you for joining us today. Next, we'll hear from Christine Ossenfort. Good afternoon, Ms. Ossenfort, please go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and members of the committee. My name is Christine Ossenfort. I represent Anthem Blue Cross and Blue Shield, and I appear before you this afternoon to testify in opposition to LD 1317. As Senator Brenner noted in her testimony, this bill would not apply only to prepayment review, but also to all reviews of medical records. And it would place significant limitations on a carrier's ability to engage in such review. And we appreciate her comments that she is not trying to interfere with the fraud, waste, and abuse process. And we'd be happy to try to work with her and the committee to address some of our concerns. We do have an obligation to our members to ensure that we are paying for the care they need and not paying for fraud, waste, or abuse. Such claims not only increase the premiums overall for everyone, but can result in members paying higher out-of-pocket costs as well, or costs that they should not be expected to pay. Claims can be reviewed for a variety of reasons, including prior authorization and utilization management, medical necessity, to ensure that claims are being submitted correctly, and of course to guard against billing improprieties and fraud, waste, and abuse. Prepayment review is an important tool that we use to protect against fraud, waste, and abuse. And while the bill does not prohibit it outright, it severely limits our ability to conduct such reviews. Sometimes these reviews are initiated directly because of something we see. Sometimes they are initiated at the request of law enforcement who may be investigating potential fraud, waste, and abuse in Medicaid or Medicare and is reaching out to private carriers to see if we are seeing the same types of things. We have several concerns with the bill as it was presented and as amended. It requires that any audit or review be conducted by a clinical peer. There may be times when a clinical peer is needed, but it's not required for all reviews. To the point of testimony raised earlier, sometimes it is reviewed by a certified coder, not a specialist or a provider. We would also note that the committee has previously addressed the issue of review by clinical peer in terms of prior authorization and utilization management. The bill would also prohibit the denial for minor documentation errors or omissions or correctable errors. First of all, we would note that providers are able to submit corrected claims today. Second, it's not clear what falls into this category. For example, we have received claims for incorrectly billed units, such as 9 pacemakers for one individual, 73 shoulder surgeries on another individual, and 112 knee surgeries on a third individual. each of those claims would have been over $1 million. If we don't know if the claim is correct, how do we pay it? Thank you. And with that, I'll be happy to submit written comments, and I will of course be present at your work session as well, and happy to answer any questions that you might have.
Thank you, Ms. Ossenfort. I appreciate the examples that you gave, but they don't strike me as being related to the bill really, because the bill is really trying to target the issue of prepayment review that's targeted at particular practices. And, you know, particularly I think about the Cape Integrated Health example. It's a practice that I have been to myself. It's a real live medical practice. Like, it's a place with real doctors there and real professionals. And, you know, I can't quite understand the notion that there's some sort of need to delay things by, you know, 9 months at a time for this small business that employs people in order to catch the 73 pacemakers, which presumably were billed to you by a hospital, which is not on prepayment review. So can you speak to why we seem to only be targeting these integrated health practices?
We're not targeting. Hospitals can be placed on and have been placed on prepayment review as well, as can physicians. The point of the example is to illustrate that the bill paints a broad brush. When you get into things like minor and correctable errors, any error is a correctable error potentially. So how do we pay a claim that it contains a minor or a correctable error? But I do understand your point about the time constraints or the length of time involved. Obviously, some cases are more complicated than others. We unfortunately do not have the capacity to accept records electronically through our provider portal today. They can't be transmitted to the business unit that conducts prepayment review. That is something we are working on, and we hope to be able to accommodate by the end of the year. But at this present time, that is an issue for us, and we acknowledge that can be create complications and delays. But prepayment review, I'm sorry, Senator, did you want to?
So I was just going to say, but as soon as you receive the paper records, they're scanned and then then entered into some sort of document management system, I assume, right?
I presume they're entered into an electronic file on the prepayment review. And that, as I said, that is a gap that we are working to address and that we want to address, because we do recognize the inefficiency. Unfortunately, the provider portal doesn't have the capability to transmit them to the unit that does the prepayment review. And that is something that we are working on and trying to address.
Okay. Senator Brenner, did you want to ask a question?
Thank you, Madam Chair. I was going to ask about the electronic submission situation. I was also told by one of the providers that the PO box was incorrect. So they were sending reams of paper in big boxes to an incorrect PO box for some time. And there was a request that it be an actual physical space where there could be tracking on the paperwork that they're mailing. What do you think about that?
That's not something I'm familiar with, but if you can share the details with me offline, I'd be happy to take a look at that. If you can.
Yeah, I'm sure those providers would be happy to share those details. Thank you.
Additional questions for Ms. Ossenfort, Representative Matheson?
Thank you so much. Could you just give us, for the work session, the criteria for a prepayment or a post-payment analysis for these integrative providers? I've been up against this as well, being an integrated provider of a clinic. So we do this as well. So I'm curious what triggers that, and maybe even just some examples of what triggers that. That would be helpful. Thank you.
Sure, I can tell you, and it's not for integrated health providers. It's for hospitals and entities like that. One of the things that can trigger post-payment review is if we see something that indicates that there might be unbundling excuse me, unbundling of services that should be part of a bundled or fixed payment or DRG type of claim. And if we start seeing separate line items for things that should be included in that, that is one thing that can trigger a post-service review. But I'd be happy to show you more information for the work session.
Representative Bleier.
Yes, thank you, Madam Chair. Thank you, Ms. Awesome for being here. I guess the question or the concern that I have, we've had several doctors come in front of us that claimed tracking claims for nine months, up to 2 years. And I'm wondering, I know that some claims are more complicated than others, but the claims that they were mentioned didn't seem very complicated to me. And so my question is, if we've had so many doctors come online saying that this is a major problem, why do you feel that it's not?
That's a tough question to answer tonight. I'm not saying that it's, I certainly understand their perspective, and without details, it's hard to comment on why it may take so long and whether or not that was appropriate. There may be instances, unfortunately, prepayment review does involve some back and forth, and sometimes there may be issues at our end, sometimes there may be issues at their end. So it's difficult to comment in a vacuum, and obviously, we can't discuss specifics, but would be happy to, if there are particular cases or reviews at issue, would be happy to take a look at those and try to understand what was going on in those situations.
May I follow up, Madam Chair?
Of course, go ahead.
So I understand that, Ms. Ossenfort, but even the back and forth, 12 months to 2 years, I feel like, isn't that kind of a long time unless it's something major complicated? I mean, I don't know. I just feel like the length of time is unrealistic. And so maybe there has to be a change someplace else within the way you handle claims, or there's, I just feel it's a very long time. I'm just curious.
And certainly, Representative, but I guess one of the things I'm not clear on, is it one claim that is going that, or is it the provider is on prepayment review for a period of time, or both? Because we do have, if a provider is placed on prepayment review, it is likely that they could remain there until we are satisfied that the claims are being submitted and being processed correctly. That may be a fairly quick process in some instances, and it may be more lengthy in others. But we do, once we believe the issue has been addressed, we do keep them on for a little bit longer so that we can be assured that the issue has been addressed before we take them off of prepayment review.
Representative Matheson.
Thank you so much. Yes, Ms. Ossenfort, do you have a department that does just pre and post payment issues so that practitioners can be in touch with the same person, or is that something that you're looking towards doing so that there's some continuity as they go through?
They are done by different departments. So prepayment review is done by one department, post-payment review is done by a different department.
I think the question was a little bit different than that, which was, is there a particular individual assigned to a particular practice once they're put on prepayment review, so that you can call up and say, okay, we talked about this file last week. Why isn't it approved yet? What else do you need?
I will confirm that and get back to you. I do believe that they are given the opportunity to request discussions of their prepayment review status, but I will check on whether or not there is a designated or dedicated individual for their case that serves as a point of contact.
Okay, if not, that's certainly a good suggestion for a better business practice, I think. Representative Arford, go ahead.
Yes, thank you, Madam Chair. Very simply, what percentage of practices that you have done a pre or post payment review in the last 12 months have you found to be out of order in some way? In other words, what the provider was billing was incorrect or actually necessitated that type of review?
So Representative Arford, I don't have that today. I certainly can try to get that. We do submit very general information to the Bureau of Insurance on an annual basis, and they provide actually this committee with a fraud report. So it would not be that report would not have information specific to Anthem. But I would also note it isn't just providers that can be placed on these reviews. It can be all types of providers, including hospital systems. It's not just professional providers.
So it would be great to see exactly what the outcome is of these reviews.
I think I'll also note just that I don't remember the fraud report having any discussion of, you know, what number of providers were actually put on any kind of review or something like that. I don't think that the Bureau would collect those statistics.
I apologize. Sorry, my phone started ringing while I was looking for the mute button. Yeah, I don't know that it puts specifically prepayment review to that final point on it, but I believe it does indicate the number of fraud cases identified. I think I would have to take another look at it again.
Okay, Senator Brenner.
Thank you, Madam Chair, and thank you, Ms. Ossenfort, for entertaining all of our questions. I recognize you're in the hot seat right now, but I'm wondering if you could perhaps for the work session share whatever, and maybe these are more specific, but if you had a boilerplate contract that showed terms for what pre and post payment review, what the agreement generally is between providers and the insurance company. That would be
yeah, there is a discussion of prepayment review in our provider manual. We can provide that to the committee. And then there are also sections that talk about the ability to the appeal rights, not necessarily to challenge being put on prepayment review, but with respect to claims, as well as the provisions around utilization post-payment review.
And Madam Chair, might I ask a follow-up? So in my conversations with the physical therapists and chiropractors, which I've had quite a few, as you can imagine, over the last few weeks, one of the comments was about, oh my gosh, I'm losing my train of thought. I think it's getting late. I'm sorry, lost it.
Okay.
So, sorry.
No problem. All right. Are there additional questions for Ms. Ossenfort? All right, seeing none. Next, we'll hear from Catherine Pelletreau. And Ms. Pelletreau, go ahead.
Great. Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I speak today for the Maine Association of Health Plans in opposition to this bill. The plans have several serious concerns with this bill. Overall, it seems to suggest that the plans are being punitive with their payment review rather than responsible and accountable for the premium dollars they collect. While I'm providing some comments today, this proposal needs a deep dive into its intersections with current law and an understanding of when and where these changes are intended to apply. Some of the language seems to toggle between medical and administrative reviews, for example, and it's not clear what is intended. 1317 would require a clinical peer licensed in the state to practice in the same profession as the provider being audited, to conduct any audit or review, and to be the sole contact person for the provider for any questions. In effect, this language would require carriers to have on staff sufficient providers of every discipline to handle administrative as well as substantive aspects of claims review. Meeting this requirement alone would add tremendous administrative costs that would be passed through in premiums. Electronic claims adjudication results in the vast majority of claims being auto-adjudicated. These systems cannot be programmed to catch things like misspellings, abbreviations, and correctable errors. It's common for claims to be denied and then resubmitted with the corrected information and paid. If the claim is denied on a medical basis, providers can appeal. In 2019, the Bureau issued, well, it's actually, I think, more recent than that, but it's a 2019 report on tick-borne illnesses, and it gives a good example of common reasons for denials and the high numbers associated with administrative errors, such as duplicate claims. In that report, out of 1,053 total denials in 2019, 421 were for duplicate claims. Permitting a provider to both appeal, actually, I'm going to skip this because it sounded like there was already an amendment underway to address that problem. So just to close, we urge the committee to consider that these are not widespread problems across providers or across health plans, and to oppose this legislation. Thank you.
Thank you, Ms. Pelletreau. When you say it's not a widespread problem across providers, do you mean to say that it's targeted specifically at acupuncturists and physical therapists and chiropractors? Because that's certainly the testimony that we heard today.
Yeah, no, that's not what I intend. And I represent an association, and Anthem is a member of it, as well as the other carriers. And I can tell you that in my conversations with our membership preparing for this bill, not all the plans are experiencing these same types of problems. In fact, not all the plans have a prepayment review list or category.
Okay. So by experiencing the problems, you mean conducting this sort of business practice?
Correct. Well, and I don't want to say that there are not reviews on claims, because there are. I mean, there's lots of things that could trigger a review. The fact that a claim is a high cost claim could trigger a review. And certainly fraud is another thing that could trigger a review.
Okay. Representative Arford.
Yeah, thank you so much, Madam Chair, and thank you, Ms. Pelletreau, for being with us. I very much respect your ability to provide us with straightforward and honest information. And so my request to you, and you may not be able to do this, but I will make the request, could you provide us with a breakdown by provider of what practices that we're discussing today they do engage in? Or is that something that you simply would not have access to, that type of information?
I don't think I could get a list of what each carrier does for each change that the bill is proposing.
No, I'm talking about do they do the post-payment reviews and the prepayment reviews? You made a comment earlier that not all carriers engaged in that type of business practice.
Or certainly not in the same way. So yes, why don't I come back to you with some more information on that from the other providers?
Thanks. Are there additional questions for Ms. Pelletreau? All right, seeing none, Ms. Cook has her hand up, so we'll next hear from Kimberly Cook. Good afternoon, Ms. Cook, go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. My name is Kim Cook, and I'm here on behalf of Community Health Options. And I wanted to, we are currently preparing some testimony so that we can submit information for the committee's consideration before the work session. We didn't have that ready in time, but I did want to comment that we now, I think, have a better sense for what the issue is that the bill is trying to address. And so this hearing has been helpful for us in preparing information that might be useful for the committee's consideration. And also wanted to thank Senator Brenner for her comments about trying to work with all the parties to address these issues. And so I wanted to certainly thank her for that and say that we stand ready to work with the sponsor and the other organizations involved to come get the bill in a place where maybe we can all be comfortable with it. So thank you for that.
Okay, thank you, Ms. Cook. Are there questions for Ms. Cook? All right, seeing none, we'll look forward to receiving your testimony. Okay, are there any other individuals in our Zoom meeting who wish to testify in this hearing? Seeing none, I'll close the hearing on LD 1317. Next we will pick up, checking my list here, LD 1268. Yep, LD 1268. And I think Senator Stewart is with us. His camera's off, but he's there. Great. And so our own Senator Stewart will present the bill. Welcome, Senator Stewart, and go ahead.
Oh, hang on just one second. Just gotta pull up the.
Sure.
There it is. All right. Good afternoon, Senator Sanborn, Representative Tepler, and my fellow colleagues on the Committee on Health Coverage, Insurance, and Financial Services. I am Senator Trey Stewart. I have the distinction of representing 51 communities in Aroostook and Penobscot counties. And I'm before you today to present LD 1268, an act to provide greater access to treatment for serious mental illness by prohibiting an insurance carrier from requiring prior authorization or step therapy protocol. I doubt there is a legislator among us who has not had a family member, friend, or constituent experience a mental health crisis during the COVID-19 pandemic. I know we've all heard of how difficult it has been for people to access mental health treatment in Maine during this time as well. These challenges have been felt nationally, which is why we have seen governor's offices and legislatures across the country address the need for telehealth access and reduce barriers to other forms of mental health prescription drug treatment in Medicaid and private insurance. Experts have indicated that mental health problems that have worsened during this time will last far longer than the pandemic itself. Now is the time to reduce healthcare barriers and barriers for some of our sickest fellow citizens. This bill seeks to eliminate 2 barriers to mental health treatment for a targeted group of adult patients, those with serious mental illness. Serious mental illness includes schizophrenia, spectrum disorder, severe bipolar disorder, and severe major depression. These conditions, if treated poorly or left untreated, make it incredibly difficult for a person to function, and even prior to COVID-19, were known to lead to a higher risk of suicide, homelessness, incarceration, and hospitalization. The first barrier is prior authorization. As the committee has heard in recent hearings, prior authorization means the patient or the physician has to get permission from the insurance company before covering a drug the physician prescribes to the patient. Typically, the physician has to tell the insurance company that a drug is medically necessary for the patient. The second barrier is step therapy, or known as a fail first, and a protocol imposed by insurance carriers. This process obligates patients to try a drug preferred by the insurance company, and to fail on that drug, the drug is not effective for them, and the drug has an undesirable side effect for them, which is what that definition means, before the insurance company will cover the drug that the patient's doctor has prescribed. Such policies are particularly dangerous in mental health treatment, where they can be associated with higher risk of patient discontinuing medications, which leads to adverse outcomes and much costlier patient care and societal impacts. While many patients with serious mental illness end up on Medicaid, patients experiencing initial episodes of their disorder are typically young adults who often are still on a parent's private health insurance plan. The legislature previously has found ways to reduce these barriers for a broad swath of patients. In 2019, we passed a law to restrict insurance companies' use of step therapy by providing procedural protections for all patients facing step therapy protocols. This committee also just recently considered bills that aim to help patients and physicians by making prior authorization information more readily accessible. At times, however, we have recognized the importance of exempting certain patients from the step therapy and uncertainty of dealing with barriers to treatment like prior authorization and step therapy, which can come with multiple levels of internal insurance appeals to the Bureau of Insurance, and even potential litigation. For example, in 2019, we passed a law to exempt from prior authorization requirements pregnant women who are prescribed drugs to treat substance use disorder. Similarly, other states have outlawed step therapy for particular medical conditions. The COVID-19 pandemic has affected the mental health of so many people in our state. And I believe that this legislation will help some of the sickest among us in this difficult time. I do wish to note that it has been suggested to me that from a drafting perspective, the prohibition on step therapy should be moved to section 43020-N, and I would be amenable to including a step therapy exemption for serious mental illness in that section and removing it from the current section, which is 4304 as drafted, and we can talk about that more in the work session. Thank you very much for your time and consideration of this important legislation. Happy to answer any questions that the committee may have at this time.
Thank you, Senator Stewart. Are there questions for Senator Stewart? All right, seeing none, we thank you for bringing us the bill. And next we'll hear from Representative Patty Hymanson. Good afternoon, Representative Hymanson, go ahead.
Good afternoon, hardworking HCIFS committee. Good afternoon, Senator Sanborn, Representative Tepler, and members of the Joint Committee on Health Coverage, Insurance, and Financial Services. I'm Representative Patty Hymanson, and I represent parts of York, Wells, Sanford, and all of Ogunquit. I come before you today to speak in favor of LD 1268, an act to provide greater access to treatment for serious mental illness by prohibiting an insurance carrier from requiring prior authorization or step therapy protocol. I'm speaking in support of this bill, which would remove the requirement for prior authorization and step therapy for a group of medications. I have never seen or heard evidence that documents the cost savings or care improvement that these two insurance industry generated barriers to the medical professional patient relationship and good patient care have achieved. And I've looked for that, and I've asked about it, and I have never heard it, seen it. I speak to you now as a neurologist who practiced in offices and hospitals on the Seacoast for 26 years. Insurance companies required step therapy for migraine treatment. Those steps only frustrated me and made the patient suffer as we worked through the steps until we got to the medication I wanted to prescribe in the first place. I could hear my administrative assistant on phone calls about prior authorizations. I was never denied a request, but I felt as though I should bill the insurance company for the time my administrative assistant, who I paid, was actually working for the insurance company to improve their profits, not the health and not the care of my patients. You can hear my frustrations around prior authorization and step therapy, and I think you have heard this before, and I know you're working on that. Thank you for working on both of these important issues for the sake of our patients. When you consider carving out prior authorization and step therapy, quote, prescription of medications used to assess or treat an enrollee's serious mental illness, end quote, that was quoted from the bill in front of you. There are a few things to consider. Medications used to treat these disorders are often used to treat other problems. An example is divalproex, used to treat migraine, epilepsy, and bipolar disorder. A prescription does not indicate the diagnosis, and it's a commonly used medication for all three of those disorders. There is an exception in Maine law in the 127th legislature, we passed into law prescription monitoring language that prohibited doses of morphine above a certain number. But if a prescribing provider indicates the diagnostic code and the exemption number on the prescription, it can be filled in higher doses. No authorization is necessary through that process. This was a struggle to implement, but seems to work reasonably well now. I would not advise enlarging this process for a group of medications. It would be confusing, time-consuming, frustrating, and bureaucratic, and ultimately harmful to the patient. Allowing only providers who specialize in, quote, serious mental illness, end quote, defined by the Diagnostic and Statistical Manual of Mental Disorders, and quote, results in serious functional impairment, end quote, both of those quotes are from the bill, to carve out prior authorization and step therapy from these medications would be problematic because other providers treat these disorders or refill medication prescriptions when people are clinically stable. Some of these medications are used in combination. In conclusion, I strongly support efforts to take away prior authorizations and step therapy. This bill offers challenges to find a way that does not further encumber the prescribing provider, and I urge you to look at solutions through that lens. Thank you for your attention and consideration. I'm happy to take questions and answer them as I'm able.
Thank you, Representative Hymanson. Are there questions for Representative Dr. Hymanson? All right, seeing none, thanks for joining us today.
Thank you.
All right, next we will hear from Jean Gore. And just a reminder, I'll wait for Jean to join us. Just a reminder that we will be using a 3-minute clock for all except those who are serving in the legislature. So thank you very much. Ms. Gore, nice to see you again. Please go ahead.
Good afternoon again, Representative Tepler, Senator Sanborn, distinguished committee members. My name is Jean Gore. I'm a resident of Shapley, and I am the parent and legal guardian of a young man who suffers from schizoaffective disorder. I'm testifying in support of this bill. As his guardian and his mom, I am often the one to manage his medications. It's beyond me why there's a need for prior authorization or step therapy, which is really a practice of making someone fail first of the medications his doctor has prescribed. But I can tell you it happens frequently. When my son was in charge, when my son has a change in medication, it's often because his previous medication stopped working. This inevitably leaves him in a very fragile state, psychotic and agitated. To be told that my son cannot have access to the medication his provider thinks is the right one for him creates major anxiety on both my son's part and my own. It's stressful for him and it's stressful for me. We have all probably experienced a time when we couldn't get the medication our provider thought was best for us. For those of us who can advocate for ourselves, it's hard enough. When someone suffers from a brain illness, they may not be able to advocate for themselves, and the consequences can be devastating or deadly. I remember when we couldn't get the right medication for my son and being in a crisis situation for an entire weekend. Ironically, I had a discussion this morning with a family member who has been waiting 3 weeks for prior authorization for a drug. I believe it's called Capleta, which is it's an atypical antipsychotic. It's very important for patients living with brain illnesses to have as many options for medication management as possible. It's also very important for them to remain stable on their medication. Every time they become psychotic, they lose brain cells. It's often hard to find the right medication, and once you do, No one should have to live with the stress and constant worry that the formulary is going to change or that you have to try a medication and fail on it before you can get the one your provider thinks is best, or that the formulary might change in the middle of the year. One shouldn't have to go back and forth constantly with an insurance company about whether they will approve something. Why should we have to appeal for something the provider thought was best in the first place? For patients living with serious mental illness, any barrier, even the smallest one, can mean the difference between stability and daily functioning versus a psychotic episode and a spiraling downward. The consequences are dire in some cases and impact not just the person living
Ms.
with
Gore,
the
can you wrap up your
illness.
testimony for me?
Yes, but all those who love and care for them. I'm also the coordinator of the National Shattering Silence Coalition, and it's made up of family members. I hear all the time from family members in a panic because they can't get a hold of their doctors and they can't get their child's prescription. Please, please eliminate these barriers and allow them to live the best lives possible while managing their very challenging brain illnesses. Thank you.
Thank you, Ms. Gore. Sorry, committee, bear with me for just a moment. I had Ms. Gore's testimony open, so I have lost my list. There we go. Are there questions for Ms. Gore? All right, seeing none, we thank you for giving your personal testimony today. Next, we'll hear from Hannah Longley. Good afternoon, Ms. Longley, please go ahead.
Good afternoon, Senator Sanborn, Representative Templer, and distinguished members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Hannah Longley, and I represent NAMI, Maine. As the state's largest grassroots mental health advocacy organization, NAMI, Maine supports the passage of an act to provide greater access to treatment for serious mental illness by prohibiting the insurance carrier from requiring prior authorization or step therapy protocols. For the 1 in 4 Mainers who have a mental health diagnosis, life with a mental illness can be complex and a difficult journey, full of significant barriers and obstacles. By eliminating step therapy or fail first policies the insurance companies have put in place, this committee could be providing life-changing and potentially life-saving policy. Mental illness has a root in multiple biological and experiential factors, resulting in the need for provider patient-driven response that is dictated on an individual basis. NAMI Maine has heard many heartbreaking stories arise from individuals who were prescribed a medication found to be effective in treating symptoms only to be forced to discontinue the use due to mandates brought forth by insurance companies. Although these policies have been put in place by insurance companies as a cost-saving measure, it's been found that it can lead to more costly and catastrophic outcomes. This includes loss of work and relationships, lasting cognitive impacts, homelessness, incarceration, hospitalization, and even suicide. One sad story that was relayed to NAMI Maine was in regards to an individual who was hospitalized due to a mental health crisis. They were then stabilized on an inpatient unit and were discharged into the community. When they went to fill their prescribed medications that had assisted tremendously in stabilizing their symptoms, they were informed that they would have to work with their provider for a prior authorization. Due to the lengthy wait list, the individual is left without medications while trying to navigate what can be a very complex system. As a result, the individual's symptoms returned, they decompensated, and felt overwhelming hopelessness, and resulting in them dying of suicide. Depression should not be a terminal illness. As it stands, the stigma and barriers surrounding mental illness results in individuals waiting on average 10 years to seek treatment. Once an individual is able to step forward and seek treatment, their provider should dictate the most appropriate course of treatment, not insurance companies. We ask this committee to ensure that these barriers are removed to support the 1 in 4 Mainers living with a mental health diagnosis. Thank you, and I'd be happy to answer any questions.
Thank you, Ms. Longley. Are there questions for Ms. Longley? Okay. Ms. Longley, I have a question about the example you give in your story or in your testimony. It seems like discharging somebody from the hospital without having then a provider that they're being handed off to manage their medication is a real problem. It's a separate problem than what we're talking about today, but can you speak to that just for a little moment? It's getting late in the day, so I don't want to open a can of worms, but that seems like a real problem.
Yes, I was gonna say that's a huge can of worms, and I thank you for bringing attention to it. Discharge planning does occur and referrals are made. Right now, what we're seeing is there are extensive wait lists. We have a critical shortage of providers, mental health providers here in the state of Maine, particularly those who are willing and able to do prescription medications, prescription psychiatric medications, because it is such a specialty. And because we have such a shortage, we're seeing people who are sitting on wait lists for longer and longer periods of time. What we know is that as that period of time progresses, and for a lot of individuals, when they are experiencing a mental health crisis or a mental health challenge, their ability for decision making and for structure and for organization can really be impacted significantly in the frontal part of their brain. As a result, those wait lists and all of the processes and the policies that are in place really have a significant impact on them. But yes. Okay. Provider shortage is a critical issue here in the state as well.
Okay. Wouldn't it be the prescribing provider who would be responsible for the prior authorization to bring it back to the bill? Wouldn't that be the person in the hospital who wrote the prescription?
It would, yes, with referrals out. And again, what can end up happening is that when you experience that mental health crisis and that mental health challenge, as more barriers are put into place and you try and seek out, this is the place to go, no, this is the place to go, and you get the turnaround, representative, oh dear, I forgot the representative, the doctor who just,
Hymanson. Yep.
Yes, she would be able to speak far more acutely to this as a neurologist. But really what ends up happening is that as that part of the brain is being impacted with all of that, you have to go here and then you have to go there, people become overwhelmed, and that part of their brain where the organizational part of their brain is being impacted, and it becomes too overwhelming and creates significant barriers.
Okay, that's helpful clarification. Thank you. Are there other questions for Ms. Longley? All right, seeing none. Thank you for joining us today. Next, we'll hear from Holly Lusk. Good afternoon, Ms. Lusk. Go ahead.
Good afternoon. I'm trying to get my video started. There we go. Here I am. Hello, everyone. Representative Tepler and Senator Sanborn, members of the committee, good afternoon. My name is Holly Lusk. I'm a lawyer. I live in Harpswell, and I'm here today on behalf of Synovian Pharmaceuticals. Synovian is a New England-based drug company. It's been in business for about 10 years, and we research and develop medications to treat chronic illnesses in 3 different areas. One is chronic lung disease, one is neurological conditions like Parkinson's, and another is serious mental illness, such as some of the conditions that Senator Stewart mentioned today. We're here to support the bill because it restores some power to the doctor-patient relationship that has been stripped in years past by insurance companies. I want to be clear in terms of our support of this bill, that, because I've read some of the testimony from the health plans that this is about things that we make and about things that we have in our pipeline. It is absolutely true. We make medications that treat serious mental illness, and we are researching medications to treat serious mental illness, and we are proud of that. This bill is not about any of the drugs that we make in particular. It is encouraging doctors and patients to be able to make scripts for whether it's our drugs or someone else's drugs or a generic or a brand name. The real issue comes down to what the doctor and the patient think is best based on the discussions that they have. We are not asking for all drugs to be offered at an equivalent cost share. What we are looking for and would encourage is for plans to have the broadest formulary possible and without barriers like STEP and like prior authorization. And why is that so? It is because serious mental illness is incredibly difficult to treat. It is notoriously difficult to treat with medication. These types of drugs can be unpredictable in terms of which patients will respond to which ones and which side effects patients may experience. That is one of the reasons why it often takes someone multiple drugs to be able to find the one that works for them. It's also why, at least for one of the conditions that we've been talking about, which is schizophrenia, the American Psychiatric Association has been very clear that from a clinical perspective, in their guidelines for treating schizophrenia, there can be no algorithm to order the medications that apply for this particular condition. So I'm happy to talk about the current STEP therapy law, how your prior authorization work that you're doing right now can come into play with this particular law. But I would simply say that patients with serious mental illness who are recognized by the department as patients with special needs should not be required to go through the same processes as other more resourced patients. Thank you.
Thank you, Ms. Lusk. Are there questions for Ms. Lusk? So I have one. We have already passed, I think, this session, a bill requiring sort of real-time prior authorization processing. That strikes me as basically solving that piece of this bill. Because if the provider can complete the prior auth and is alerted to it within that electronic medical record process while they're prescribing it, haven't we solved that piece? Because I think we can, the step therapy exception makes sense, and we have a structure of step therapy exceptions. But I'm curious about your thoughts on why this prior authorization rule is not going to solve this issue.
Sure. Well, let me first say that I think it was a great bill. I think that having real-time information available to a physician, both in terms of what the recommended drug would be from the carrier and also what the cost share would be for the patient, is incredibly important. I think that doctors, especially today, are exquisitely attuned to drug costs and their patients' ability to pay for various medications at various levels. I think that's a discussion that should happen within the context of the doctor-patient relationship. It's something that can happen in the room, and I think that doctors have gotten very good at having those conversations. That being said, because there's a real-time response doesn't mean that the answer from the company, from the carrier, is going to be yes, you can have that drug. The answer might be no, you cannot have that drug, you have to do something else. And I think that is part of the challenge, is that, you know, again, the real-time response doesn't mean that the real-time response is yes. And I think what we're trying to get at is, what is important is for the doctor and the patient to be able to make the decision as to which drug is right for them. The APA, the American Psychiatric Association, has been very clear that there is not a clinical order for which drug is better than which. And so for there to be some algorithmic approach to drugs is just not appropriate in the confines of some of these serious mental illnesses, including schizophrenia. So I guess I would respond in that way. I think it's an incredibly helpful bill in so many ways. I think that it doesn't get to the yes that the doctor and the patient are looking for, though. It could be that you will hear from carriers that 98% of prior auths are approved. I mean, again, I would say, what's the point in doing prior auth if they're all approved? But I think it's important for the end decision to be made by the doctor and the patient, and I'll leave it at that.
Okay, are there additional questions for Ms. Lusk? Representative Melrano.
Can you hear me okay?
I can, yes, thank you.
Great, thank you, Madam Chair. Thank you, Ms. Lusk. I don't want us to lose sight of why step therapy and prior authorization, though they're not at all perfect solutions to this. Do you understand that the root of this problem are the outrageous costs that Americans are charged by pharmaceutical companies, like the type of company that you represent?
I would say, Representative, and thank you for the question. You know, having heard some of the testimony over the last couple of days, I think that we would not be human if we didn't have a response to what we heard from some of the patients. I can say personally, as a family member of someone with schizophrenia and someone with bipolar, I can understand what some of the significant challenges can be for patients trying to access medication. I will say that what we have heard from the carriers is that this is not all about drug prices. You know, some of these decisions are just based on clinical recommendations. And I would argue that for some of these conditions, it's not clinical recommendations. It is simply cost-based. For some patients, that cost basis is going to matter, and for some of them it's not. You know, people come in all varying shapes and sizes and income levels, and for some people those things will matter, and for some of them it will matter less. But I will say that, you know, for what we have on the market, and I'm happy to send you information if you have interest. For patients on Medicaid, our antipsychotic is about $9 a month. For patients on Medicare, our antipsychotic is about $8.95 a month. For patients on private health insurance, our antipsychotic is in the realm of $100 per month. So that's what I can tell you about what we produce and what is on the market for us. You know, there's nothing in this bill that prohibits a PBM from negotiating great drug prices. There's nothing that will affect that. They have every right to try to make a great deal for people who are paying at the end of the day.
Thanks, Ms. Lusk. Are there additional questions? All right, seeing none, next we'll hear from Dan Morin. Good afternoon, Mr. Morin, go ahead.
Hi, thanks, Senator Sanborn. Hi, Representative Tepler, members of the committee. My name is Dan Morin with Maine Medical Association. I handle communications and government affairs for the state's largest physician organization that branches across all specialties, organizations, and practice settings. You should have your testimony before you. I'm not going to touch on things that other people have touched on. I may make some random comments, but the patient population, as I'm sure many of you know, covered under this bill, are particularly vulnerable. Psychiatric medications aren't like other medications. They're far from fast acting in many cases. What works for one may cause harm to another. We're talking about illnesses such as depression, schizophrenia, bipolar, other mental health conditions, and severe mental illness that are caused directly by chemical imbalances in the brain. It's not unique. It's not one size fits all, hip replacement or ACL injury. 1 in 3 Americans suffers from severe anxiety, and 1 in 4 battles depression. I've got some experience in this with a close family member. So when I was talking to members about this bill, I could actually see visually what we had experienced as a family through what some of the physicians were telling me they struggled with. Most importantly, through experience and through member contact, there's a titration process along with a lot of severe mental illness prescriptions where you start with a low dose, you gradually increase. Sometimes it takes a few weeks, sometimes it takes a month, sometimes it takes 6 weeks. Sometimes you don't get any relief initially, but you have this intense side effects, and that can be difficult to judge too. So there's a lot of things going on in a person's life when they're trying to get to that perfect mix of medicine when they talk to their physicians. So not only that first part, there's also a second round of waiting game. What about another 30 to 60 days waiting to see if it takes effect? Not all medicines work for everyone. And sometimes it's necessary to do one medication at a time, try 2 together, try 3 together. And if you talk to people, and you'll hear it today, they're terrified to be forced to change medicine. And one other thing, sometimes it's not their fault. It might not be just a step therapy process in one person for one insurance carrier. Sometimes an employer might change plans, or they might have an unplanned loss of a job. They may be unemployed or part-time and be on main care. And in their previous coverage, they have a good mix of their prescriptions. And then all of a sudden they might get full-time employment, or their company changes plans. And then they're told they can't continue with the medications. that have been successful, sometimes for months, sometimes for years. So Holly touched on the physician-patient relationship. You know, you're going to hear about that. I love the point that she made about if 98% or 90 are approved, then why have it? Because all you're doing is confirming that the physician-patient relationship is working. And the consequences of not passing this are in my testimony also, and they were highlighted by Ms. Longley from NAMI. So I hear a lot of conversations in this committee, especially medical billing last year. Who cares about the provider? Who cares about the carrier? It's about the patient. Well, I'll close with patients first, not fail first. Please support this bill.
Okay, thank you, Mr. Moran. Are there questions for Mr. Moran? All right, seeing none, we thank you for being here today. Next, we'll hear from Caitlin Morse. Caitlin Morse, are you there? I have an empty box so far. There you are. Okay, Ms. Morse, go ahead.
Thank you. Good afternoon, Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Caitlin Morse. I am a resident of Westbrook and the Policy Associate of the Alliance for Addiction and Mental Health Services. At the Alliance, our members represent the full continuum of behavioral health and peer recovery supports. I am here to submit testimony in support of LD 1268, an act to provide greater access to treatment for serious mental illness by prohibiting an insurance carrier from requiring prior authorization or step therapy protocol. Step therapy and prior authorization are some of the most frequent roadblocks for psychiatrists to prescribing an optimal treatment regime. Yet the majority of insurance companies working with large employers in the United States make these requirements. For our members, these are processes that make work more difficult and care less effective for their patients. It is a system that saves insurance companies money by denying medical care that has been determined necessary by a physician. Requiring patients to try lower priced medications or other treatments before taking a step up to the right treatment that may cost more is a potentially dangerous process. The job of a doctor is to find the best fit for patients based on potential side effects and response in relation to their condition. Appropriate medication options provide better care and improve results. Requiring patients to prove that they need medication and treatments as prescribed places all the power in the hands of the insurance companies. Fail-first policies and requirements for authorization only allow psychiatrists to pursue different drug options after other treatments fail. Forced drug switching, treatment gaps, and cessation of effective therapy are dangerous to patients because of the potential for non-response flares and relapses. Not to mention that the process imposes a major workload on psychiatrists and takes time away from patient care, drawing the treatment process unnecessarily on. Workforce availability for behavioral health supports is a problem in Maine. Adding unnecessary steps drags the process on and makes it more difficult for patients to get the care they need. Step therapy can be harmful to patients, and even when clinicians believe a different therapy is medically in the best interest of the patient's condition, insurance companies may prohibit patients from attaining affordable access. Choosing medicines based on price or profit is arbitrary and inferior. Decisions should be made on the best interests of the patients, not the insurers. At the Alliance, access to fair treatment and appropriate services for the most vulnerable members of our community is one of the issues we feel most passionately about. Our members work to keep people healthy and secure in the social safety net. Step therapy and prior authorization requirements stand in the way. Obtaining appropriate treatment the first time around is necessary for patients, and as such, we believe support for LD 1268 is essential.
Whoops. Okay, good timing. The button alarm went off just as you finished your testimony.
I saw that.
Thank you for that. Are there questions for Ms. Morse? All right, seeing none, I will do a last call for anyone who wishes to speak in favor of the bill who may be in our Zoom meeting. Please raise your hand at this time. Seeing none, we'll go on to those who wish to speak in opposition to the bill, and I'll call on Sam Hollemeyer. Good afternoon. Good afternoon, Mr. Hollemeyer. Go ahead.
Thank you, Madam Chair. Thank you, Chair Tepler, members of the committee. My name is Sam Hollemeyer, and I'm here today on behalf of PCMA. And I want to thank you for allowing me to testify in opposition to LD 1268, which deals with step therapy. Again, PCMA is the National Trade Association representing pharmacy benefit managers, which administer prescription drug plans for millions of Americans with health coverage. I want to outline that PBMs exist to make drug coverage more affordable by aggregating the buying power of millions of enrollees through their plan sponsors and payer clients. I did submit written testimony, but I want to highlight some of those important parts now. And our industry is concerned about LD 1268 and how it would limit step therapy but we believe it will remove one of the tools we use to provide a high quality benefit, which puts downward pressure on the rising cost of prescription drugs. Step therapy requires an enrollee to try a medically appropriate first-line drug, which is typically a generic alternative to those more expensive branded products when a therapy is initiated. Again, some of these brand name drugs have a very high list price, where step therapy encourages to try proven, safe, and cheaper alternative therapies first, typically generics. Back in 2019, Maine did pass a step therapy law that outlines criteria in an exceptions process. And to go further on that in exceptions process, every plan and PBM has a process that will permit the coverage of a drug that is a step therapy drug, or if a physician approves information or provides information about side effects that the patient has experienced from a lower tier drug, or offers another documented medical reason. Plans and PBMs use pharmacy and therapeutic committees that are comprised of independent experts, including physicians and pharmacists, to help create these step therapy lists to assure cost controls do not impair the quality of clinical care. I do want to wrap it up that these problematic concerns I noted previously, that we must oppose LD 1268, and I'm happy to work with the committee and key stakeholders on this, and I'm also happy to answer any questions of the committee at this time. Thank you.
Thank you, Mr. Hollemeyer. Are there questions for Mr. Hollemeyer? All right, seeing none, we thank you for being here.
Thank you.
Next, we'll hear from Christine Ossenfort. Welcome once again, Ms. Ossenfort. You can go ahead.
Thank you, Senator Sanborn, Representative Tepler, and members of the committee. My name is Christine Ossenfort. I represent Anthem Blue Cross and Blue Shield in South Portland, and I appear before you this afternoon to testify in opposition to LD 1268. I won't repeat the concerns expressed by Mr. Hollemeyer. I would note that the legislation as drafted is very broad. Serious mental illness that results in serious functional impairment that substantially interferes or limits with one or more major life activities. It can be quite broad. We would note that the legislature has previously addressed the issues of both prior authorization and step therapy. There are processes in place for expedited review as well as expedited appeals in the event of a denial. We are concerned that it would create a different process and treat behavioral health prior auth and step therapy differently from medical. And with that, I'd be happy to answer any questions that you might have, and I will of course be present at your work session as well.
Thank you, Ms. Ossenfort. Are there questions for Ms. Ossenfort? All right, seeing none, thank you for being here today. Next, we'll hear from Catherine Pelletreau. Good afternoon, Ms. Pelletreau, go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans, and I'm here to testify in opposition to this bill. As you've heard, the committee has done recent, thoughtful, and comprehensive work on both prior authorization and step therapy. The step therapy standards that were passed in 2019 include clinical review criteria, consideration of atypical populations and diagnoses, access to clear, readily accessible, and convenient exceptions processes, including specific timeframes for communication between the parties. This is a new law and only became effective January 1st of 2020. And just a few weeks ago, as you've heard, and as you acted on, the committee passed real-time electronic prior authorization for prescriptions. Our members read the language in LD 1268 as prohibiting carriers from applying prior authorization or step therapy utilization management to any mental health or substance use disorder drug. Many of these drugs have multiple indications for use, as you've also heard in previous testimony, and carriers would have no way of limiting their use to serious mental health disorders without prior auth. Carriers would not be able to provide utilization management to control for inappropriate use or cost when lower cost alternatives are available for any drug that can be used to assess or treat serious mental illness. Note that lower cost generics are widely available for antipsychotics and antidepressives. As with many efforts like this, we urge the committee to look below the surface at the market dynamics at play. Thank you. I'm happy to take any questions.
Thank you, Ms. Pelletreau. Are there questions for Ms. Pelletreau? And to be clear, Ms. Pelletreau, when you say market dynamics, you mean the issue that Representative Melrano raised about the drug manufacturers bringing forward this type of bill?
Yes, I do. And I mean, you've heard testimony about drugs that would be able to avoid utilization review and prior authorization and step therapy that are in the pipeline for one particular manufacturer you heard, but I suspect there are also others.
Okay. Are there other questions for Ms. Pelletreau? All right, seeing none, thank you for being here. Is there anyone else in our meeting who wishes to testify against the bill? Seeing none, we'll bring the Superintendent of Insurance, Eric Chapa, in to testify neither for nor against. Good afternoon, Superintendent. Go ahead.
Good afternoon, Senator Sanborn, Representative Tepler. I won't read my testimony because it's not really adding any new information other than the fact we have not received any complaints on step therapy for mental illness, but that doesn't really, not dispositive of anything. That's just all I wanted to add. So.
Okay.
Yeah,
thank you for your brevity. The committee's tired, so we appreciate that. Are there any questions for the superintendent? Superintendent, can you remind us what the time frame is for prior authorization appeal? I guess if your real-time prior authorization is turned down, what is the time frame that is required for review?
Off the top of my head, I can't, but I'm sure someone on my staff who's listening can probably type it in right as I'm speaking.
Okay.
Going,
we can circle back to it for the work session, but it would be helpful to just have that reminder and how that might have been changed by the bill that we already passed on prior authorization today. I mean, this session. Okay, great. Any other questions for the superintendent? All right, seeing none, thank you. Is there anyone else in our Zoom meeting who wished to testify verbally with regard to this bill? Seeing none, I'll close the hearing on LD 1268. And committee, we have one more bill to hear. Do we want to power through, or do you want to take a 5-minute break before we start the next hearing? Just put your hand up in the window if you need a 5-minute break. All right, seeing none, we're going to power through. And so I'll open the hearing on LD 1331, an act to make individual and small group health insurance more affordable in certain high premium counties, also brought to us by our own Senator Stewart. Senator Stewart, go ahead.
Thank you, Madam Chair, and I will try to be as brief as I can with this. I know I'm the last thing standing between the conclusion of the day. So again, I'm Trey Stewart, State Senator in District 2, and I'm before you today to present.
Senator Stewart, I apologize. I'm being so rude. I apologize, but I did want to just announce, because people might not have seen their email, that we have gone ahead and canceled the work sessions for this afternoon. So I apologize so much for interrupting you, Senator. I just forgot to mention that, and there might be someone in our Zoom meeting who's waiting for those work sessions. So if you are free to go, and we will let you know when we reschedule that. We're running out of daylight today. So I apologize again, Senator Stewart, go ahead.
That's all right. Back to 1331, an act to make individual and small group health insurance more affordable in certain high premium counties, another succinct title. When it comes to the pricing of individual and small group health coverage policies, Maine is split into 4 different geographic rating areas, and current law permits rates to differ by 50% based on the individual or small employer's location. This means that someone living in Aroostook, Washington, or Hancock County, who is the same age and health condition as someone in Cumberland, York, or Saginaw County, could be paying 29.8 to 47.6% more in premiums. And I did try to attach a helpful spreadsheet to my written testimony, and apparently that the system wouldn't accept it, but we did email that out to the committee, so you all should have that in your inbox for reference. From a public policy perspective, it makes sense that we would take age, smoking status, and other health-related issues into consideration when determining rates for health insurance. However, rate disparity based on geography simply doesn't make sense. Additionally, the 4 geographic lines seem arbitrary, as someone living in Bucksport, which is in Hancock County, is paying higher premiums than someone in Orrington, which is in Penobscot County, even though they use the same hospital and the same doctor. This is also the case between those living in Island Falls in Aroostook County in my district and someone living in Medway in Penobscot County, just one town over. The percentage difference we see between the two in some cases translates to thousands of dollars per year for the same coverage. Another point worth noting is that the population in Area 4 is only 11.4% of Maine's entire population. The Area 3 population of younger people than 65 is only 9.2% of Maine's entire population over 65 years of age and younger. A higher percentage of people on Medicare and MaineCare will result in more cost shifting to private insurance because the government programs reimburse providers at a lower rate. The legislation before you will reduce the geographic rating factor to a maximum of 1.5 to 1.35 in the year 2023 and down to 1.25 in 2024 and subsequent years. This also directs the superintendent of insurance to report on how these changes are impacting the insurance markets. The disparity based on geography is glaring, and I believe that as we seek ways to make healthcare more accessible and affordable and reduce the premium gaps, this will help better serve all Mainers. With the disproportionately higher price for some of the poorest regions in our state, we are promulgating the problem of inequality in these areas that exist between their more urban counterparts. This is one place where we can directly point to state government's policies making life harder in rural parts of the state and doing so to the benefit of regions like the Portland area. This glaring inequality in our laws should be reversed if we are to ever restore confidence in the notion that we are together one state instead of two. Contrary to what some might believe, the cost of living in rural Maine is often more expensive than living in urban centers. This is true in terms of energy costs, education costs, property tax, and indeed insurance costs. If we want people to live and work in rural Maine and not just the urban and coastal areas, we need to ensure that we aren't putting up barriers to their success living there. This bill seeks to address that problem and bring us a little closer to parity between rural and urban Maine communities, and will help to restore confidence that we are stronger together as one. Thank you very much for your time and consideration. I'm happy to answer any questions that the committee might have.
Thank you, Senator Stewart. Are there questions for Senator Stewart? All right, seeing none. Next, we will hear from Dana Duran.
He just sent me a message that he unfortunately had to
go.
Yeah,
Okay.
too late in the day for him.
Okay, I don't see Kate Endy on the call either. So at this point, I will ask whether there's anyone in the meeting who wishes to testify in favor of the bill. Seeing no hands go up, I will just direct the committee to Mr. Duran's written testimony, which is in our electronic files. I was all excited that we were going to hear from the Professional Logging Contractors of Maine twice in our Health Coverage Insurance and Financial Services Committee over the last couple of weeks. It's not all that common that he staffs our committee. Seeing no one in favor who's still here to speak, I will move on to those against the bill, and I'll call on Christine Ossenport. Kate is here. I just saw Kate's hand go up. Thank you, Christian. Kate Endy from Cake is here, so we'll bring her in now. Good afternoon, Ms. Endy. I'm so glad you joined us. We almost missed you.
So sorry about that. I forgot I was watching it on the YouTube. Senator Sanborn, Representative Tepler, members of the committee, good afternoon again. Kate Endy, Policy Director for Consumers for Affordable Healthcare. I know this has been an extremely long day, so I will be very brief and just say that we would strongly support this bill. And I think that Senator Stewart's remarks around, trying to correct policies that promote inequality among people in Maine. And I think that the closer we can get to not just geographic equity, but equity in health rates for all people is a good step. And I would also just like to remind the committee that although there are certain rating factors allowed for geography, age, tobacco use, that those are all built on top of each other. And so somebody who's older living in rural Maine is going to pay significantly more than somebody who's younger in southern Maine. And when you add on tobacco use, it becomes extremely unaffordable. The subsidies available through the marketplace are going to largely offset these differences for most people. The majority of people who purchase individual marketplace plans do receive a subsidy. And so whether the base rate of their plan goes up or down, that subsidy is going to go up or down to match. And so they're going to be largely insulated. But for those who do not receive a subsidy, or for those who use tobacco, it's significantly exaggerated. The ACA does not provide subsidies to offset the cost of the tobacco surcharge. But as I mentioned, it is duplicative of the other rating factors. And so if you are older, living in rural Maine, using tobacco products, then the cost of your plan can be significantly more than what others who qualify for subsidies would be getting, even if your income is within the subsidy range. And so I'll provide some more information in my written testimony, but would strongly support this bill and any initiatives to improve equity among healthcare rating. Thank you so much, and happy to answer any questions.
Thank you, Ms. Endy. Are there questions for Ms. Endy? All right, seeing none, thank you for joining us in the nick of time. And next we'll hear from Ms. Asenfort. Good afternoon, one last time. Go ahead.
Good afternoon, one last time. Senator Sanborn, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. I'm Christine Asenfort, representing Anthem Blue Cross and Blue Shield in South Portland. I appear before you this afternoon to testify in opposition to LD 1331. At the outset, we would note that this is a policy decision for the legislature. But geographic rating factors do reflect differences in healthcare costs in different areas of the state. We would note that this is inconsistent with the provisions of the Affordable Care Act, which expressly permits geographic rating. And while it will reduce premiums in certain areas of the state, it will increase costs in other areas of the state. So with that, I'd be happy to answer any questions that you might have, and I will, of course, be present at your work session as well.
Thank you, Ms. Asenfort. Senator Stewart pointed out that a very small percentage of the population actually lives in rating area 4. And so I'm a little bit, I question a little bit how much moving the rating factors downward, would actually drive costs up in the rating factor 1 area, just because there's so many more members to absorb the differential, if that makes sense. So I'm wondering if for the work session, you could help us with the math on that.
I could certainly take that back to our actuaries and ask them to give me some information.
Yeah, that would be helpful. Thank you. Are there any other questions for Ms. Asenfort? All right, seeing none, thank you for your testimony. Are there any other folks in the Zoom call who wish to testify in opposition to the bill? Seeing none, we'll move on to those who wish to testify neither for nor against. And we'll start with Catherine Pelletreau. Good afternoon again, Ms. Pelletreau, go ahead.
Good afternoon, Senator Sanborn, Representative Tepler. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans. I'm going to be very, very brief because I think you've heard many of the points that I would have made. The central thing that you haven't heard yet, at least in this public hearing, is that this bill does nothing to decrease the underlying cost of care or to address high healthcare costs. It does shift around a little bit, who's paying what, and for that reason could exacerbate the problem of people dropping coverage and ultimately leading to a smaller and sicker insurance pool, which in turn raises costs further. But really, as a state, we need to be focusing on addressing the underlying cost of care. So our suggestion is that Maine continue to use its established rating regulations and continue to look at more ways to bring down the underlying cost of healthcare that drive premiums. Thank you.
Thank you, Ms. Pelletreau. Are there questions for Ms. Pelletreau? All right, seeing none, thanks for joining us throughout the day today. And next we'll hear from Kim Cook. Good afternoon again, Ms. Cook. Go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and honorable members of the committee. I'm Kim Cook, and I'm still here on behalf of Community Health Options. And we are testifying neither for nor against LD 1331, recognizing that this is brought forward with concern for the underlying, the cost of premiums among those in rural areas in our state, and we're sympathetic to that. I did want to, and we've submitted written testimony, but to talk about the reason for the difference in the geographic variation around the state, and that is that the cost of healthcare services is higher in some areas in Maine, particularly in more rural areas, than in other parts of the state. The bill would reduce the premiums charged to people enrolled in individual and small group coverage in the rating areas where healthcare costs are higher, but it would also add expense to those residing in lower cost rating areas. For purposes of the Affordable Care Act, rating area 1, as you've heard, Cumberland, Saginaw, and York counties, and individuals living in those counties enrolled in our individual and small group health insurance would see some increase in their monthly premiums to provide the subsidy to those residing in more areas. And we would encourage the committee to seek from the Bureau or other sources what that might look like, just to inform your decision making. The passage, we also wanted to note that the passage of the American Rescue Plan at the federal level has created new opportunities for individuals to obtain coverage at lower cost through the marketplace, along with a special enrollment period, which I think you all are aware of, that's ongoing, which allows individuals to enroll in coverage or change plans. And there are a number of benefits that will, I think, reduce the burden at least over the next couple of years, and if they do become permanent, certainly longer than that. And so that is also another factor, I think, to look at along with this bill, is whether it's the right time to make this change, given the changes, at least on the individual market, for subsidies going even above 400% of the federal poverty level. So we believe that that program will temporarily lower premiums for all Mainers enrolled through the marketplace, regardless of where in the state they live. And we would just urge the committee to weigh the cost shift carefully and believe that really the best approach is to look and focus at the underlying cost of care and why the cost of care is higher in some areas, and to focus efforts on reining in the healthcare costs to lower premiums for everyone. And with that, I'm happy to answer any questions.
Thank you, Ms. Cook. Are there questions for Ms. Cook? I guess I would ask the same question of you that I asked of Ms. Austin-Ford. I know you referenced asking the Bureau to determine, but I'm not sure that the Bureau's in the best position. Maybe CHO isn't either, because I don't know if you have an actuary on staff. But you know, I think certainly the question is whether and how much this is really gonna simply be absorbed by the much larger number of lives in rating District 1. So it's a pretty small number of dollars that get cost shifted, premium dollars. Because there are so many fewer enrolled individuals. I would also note that I found it interesting that Community Health Options has the highest rate differential. It's quite a bit higher than the other plans, at least in the small group market example that Senator Stewart sent along. So it would be helpful for the work session to have some insight into that as well. Do you have more enrollees, for example, and that's why you have a higher differential, because you're finding a much higher cost that it needs to be offset or something like that? So it would be helpful to know.
I will take that back. I certainly don't know those details, but you know, we can provide whatever information. But you're right that we don't. We use contractual actuarials, so we don't really have the ability to do the analysis. I think that that would be worthwhile for the committee to take a look at as you consider this bill. So
okay, thank you, Ms. Cook. Are there other questions for Ms. Cook? All right, seeing none, we thank you for being with us all day today. And next I will bring in Superintendent Chappell one last time to give us his neither for nor against. Good afternoon, Superintendent. Go ahead.
Good afternoon, Senator Sanborn, members of the committee. I won't read my testimony. I'll just attempt to provide new information. Currently, the 2021 individual rates of geographic rating factors range from 0.89 to Area 1 to a high of 1.325 for Area 4, which is the northern part, and group rates share a similar range from a low of 0.862 to Area 1 to a high of 1.325 for Area 4. I will ask my actuary if she has any information that would be helpful to the committee. Also, we did a report in 2012 on geographic ratings, and I think hopefully that was attached to my testimony. But what also may be of interest to the committee is we've applied for a grant, a state flexibility grant for the federal government. We're supposed to hear this month whether or not we're awarded it. And part of those funds, should we be awarded the grant, is to study Maine's geographic rating in more detail. And hopefully we'll get that grant, but we have not heard yet. With that, I'd be happy to answer any questions.
Okay. Can you explain to us what studying Maine's geographic rating looks like?
Well, in 2012, we just tried to look at the claims experience, and we did come to the conclusion that the claims experience on a PMPM was higher in northern Maine in the Area 4. But we think it's time to update that study and perhaps a more thorough actuarial analysis. That's why we allocated, should we receive this grant, to do a more thorough in-depth study. I mean, it's almost 10 years old now, so. But
okay.
We can go study at the work session as well if you'd like.
Okay. Great. It would be helpful if you would just email that study on to Christian or Colleen, because it was not attached through the portal. I think the portal doesn't like attachments, so Senator Stewart ran into the same thing with an attachment. So we didn't receive the old study, and it might be helpful perspective.
I will do that.
Christian, did you want to add something to that, Christian?
Senator Stewart's attachment didn't come up because it was an Excel file. And
okay.
It will really only take Word or PDF. As for what happened with Mr. Choppa's attachment, I'm not sure.
Okay, understood. And in any case, that would be helpful additional information, and certainly be helpful for your actuary to weigh in on this other question, which is not about claims experience, which I realize is a harder one to study, but really is much more an exercise in premium reallocation.
Yeah,
the question that I had been asking is about like sort of weighted premium. And I feel like it would be fairly, I don't know how to do the math myself, but I feel like an actuary could write up a spreadsheet pretty quickly that would reallocate the weighted premium and let us know what the impact on a per member per month basis in Southern Maine would be.
If we have the data, I share your optimism that it's a relatively easy exercise if we have the data.
Okay, all right. Thank you, Superintendent. Are there any additional questions for the Superintendent? All right, seeing none and seeing no one else signed up to testify, I'll give us one last call on this bill. If you wish to testify verbally on this bill, please indicate by raising your hand at this time. And seeing no one in the meeting, I'll close the hearing. And we will be scheduling this bill as well as all the other bills that we heard today for a work session in the coming days, as well as rescheduling the work sessions that were scheduled for this afternoon. We will probably at some point, just so the committee is aware, have like a marathon work session day, so that we can just work through the backlog of bills now that we're kind of starting to pile up. I think fortunately a lot of the work sessions are actually going to be fairly short once we are prepared for them, but I didn't want to launch us into work sessions that we're actually not prepared for, because then they're just going to take a really long time. So that was part of the rationale for not trying to push through this evening. Representative Tepler, go ahead.
Thank you, Madam Chair, and just want to, say that if we need to, we can use another day of the week with, with enough notification to committee members that it works for the majority of us. So
yeah,
the presiding officers have released us to be able to meet any day of the week that we need to.
So I'll just let you guys know that as chairs, we're going to try to avoid that. I recognize that a number of the folks on this committee have other jobs, including myself, or are in school or otherwise really have stacked our Mondays and Fridays against ourselves already. So that said, that means we're going to have to work really long days. Coming up here if we want to stick with Tuesday, Wednesday, and Thursday. But today we were just I was a little caught off guard by how long the public hearings lasted. And so we hadn't caucused these bills last night, for example, when we might have been able to be prepared to power through into the work sessions. So those are the types of strategies I think we'll use in the future, which is trying to have caucused the bills the night before, perhaps, so that we don't have to break for caucuses. So having shared that, I don't know if Colleen has anything else for us tonight.
I don't think I have anything for tonight. No, just
okay.
Tomorrow, hopefully we won't be in the same situation with long hearings. I don't think so. So because we have work sessions after hearings tomorrow too, but we'll do the best we can. Yeah.
Yeah, we'll do the best we can. And the chairs will be reviewing the schedule in the morning. And so we'll try and re-notice some of the work sessions and give folks a heads up as to where we're headed as soon as we review the schedule. There were some public hearings added for next week as well. So we may have some very long days next week as well. But we'll continue to just try and plow through the work that we do have left. As I mentioned yesterday, we have about 100 bills left to vote on this session, which is a lot for this time of year. Representative Tepler.
I just want to let the committee know that I will be unfortunately absent probably all morning tomorrow and maybe part of the afternoon as well, because I have 4 bills up for public hearing in different committees and then a work session in another committee. So apologies, but if Heather needs a break, hopefully, I guess we'll turn to our other senator.
All right, great. Thanks everybody for your hard work the last 2 days. This has been a lot of public hearings for us. We tend to have shorter public hearings in this committee. So it was good to get through those days, and hopefully we'll get a chance to turn to some of the work sessions soon. And